start the live stream and then good. Brilliant. So thank you very much, everyone, for attending this symposium, the International Symposium on Pediatric Neurosurgery and COVID-19. This is an important symposium in the sense that it's another opportunity for neurosurgeons from the world to meet up and first of all, to be colleagues. We have very connected profession, and also to look back on the last 6 months and see what are the things that we might have learned and what are the things that we might do in the next 6 months and also beyond. And it's important in the sense that, we pediatric neurosurgery, certainly in the UK, the children have not been affected, but still the systems have been extremely disrupted. So the worry is that even children don't get affected in the future. The worry is that their neurosurgical care might now start to affect with the delays. And moreover, the winter pressures will come certainly in the northern hemisphere. That's usually bad enough, but in combination with any second wave or even the existing COVID, it could be challenging. So I think we have to have a way of appraising where we are, and also use imagination and also lateral thinking to see how we can best deal with the challenges ahead. So it is a real, the first speaker is Professor Zanon, Nelci Zanon. She doesn't need any introduction to the pediatric neurosurgery world. Professor Zanon is a professor of neurosurgery in Sao Paulo in Brazil, but she is also the chairman or chairperson for the WFNS Pediatric Neurosurgery Committee. It's an important committee, particularly at these times of pandemic, and it's a real honor to have Professor Zanon join us. And I look forward to hearing from Professor Zanon on the challenges facing low and intermediate economic countries. Thank you, Professor Zanon.
Good morning. Thank you very much, Naren. It's a privilege to be here and see colleagues online. And thanks for the opportunity to share our acknowledgement and to learn with our friends. It's a different way we have to meet each other. And probably this new way will stay with us for a while. We don't know how many times, but probably we'll learn for the long period, probably. And I'm sharing screen now. Hope is okay for you.
Absolutely fine, thank you.
Okay, thank you. No disclosure on this conference. And talk about pediatric neurosurgery in low and middle intermediate income countries is our reality, and it's a privilege to share some ideas. The response for this pandemic, I compare with emergency situation. We are physicians. We need to focus to saving lives, to reducing economic losses and alleviate suffering. Is our matter, our first aim to be doctors before became neurosurgeons. And some facts on COVID-19 we may discuss afterwards. We live in a culture that uncritically accepts that every one domain of life is political, most segments of the society really a matter to impose one view on others. For a while, somehow the hope science remain an exception for this. Scientists would not bring their personal political bias into their science. And physicians, we have no consensus between us, between vertical, horizontal lockdown, precautious treatment or not. No time for research clinical trials. And the urgency came to us, we need to have some decision, traditional science medicine or war medicine. And probably we have both actually running. Preparedness is a continuous cycle of planning, organizing, training, exercising. I think we have in our daily practice all these in our minds. And the situation now, it's not only for our patient, but maybe for our hospital, our city, our country, and maybe the whole planet. We have a universal impact in teaching and training. The schools closed in lockdown. The women are the majority. Some papers tell us 70 to 80% healthcare workers are in the front line of this pandemic situation. And also there is 80 times more hours per week in domestic activity for this workforce now. And the universal impact and teaching and training also became in our day-by-day decision making, because we need to do some choice and we need to take care also for our family and also for our job and our patient. Just to give you an idea, coronavirus in Brazil, how it's going now, we have the register of day-by-day death. But if we see in a long term, we don't have more than 1,000 deaths a day. Why we have such a discrepancy between these data? Because we are a continental country, and some states, some city make some days or a week to communicate the authorities. And when the information came, just go in that day, they do the communication. And the death, gender, and age, we see that more related to the elderly people, and the women less than a man are affected in this pandemic situation, and children, fortunately, less than adult patients. And what response we need to give? We need to apply our intelligence, increase security, not for ourselves, but also for our patients, our nation, our hospitals, and continue investigation in nature and source of this threat. Try to look at immunization, continue isolation and quarantine, and specific law enforcement for the operation, and try to restoring our structure. For the surgeons, all of us are in our day-by-day cancellation of routine for a while, no more elective surgery or presential teaching. Some trainees go to COVID-19 pandemic frontline, fear to contaminate family. It's only for this year, this month, this semester, or we may continue the next year with a similar situation. Nobody knows. We're just learning day by day. And even though if we have a surgical procedure, we need to take care because we have more risk for the patients also. And the good thing is maybe we are close to each other now by internet, and we perceive that we are in the Earth planet, the same nation, the same people, and we need to try to work together with not only governmental level, but institutions, society, medical association. In our particular case, World Federation, ISPN, Continental Society, and try to have guidelines to restart our learning, our teaching, and our day-by-day job, and maybe rethinking about our meeting. We have plenty of webinar online. It's a good way to keep in touch and to share our experience. And it's a collaborative work. We need to think for the next step, maybe financial assistance for individuals, for patients, for doctors, rebuild facility, maybe with another paradigm we need to build again. And we need to remind us that we have an inequity assistant if we consider above the equator and the below line. We have some necessities, not only neurosurgeon, but pediatric neurosurgery, human resource, and material resource also. In particular, for children in low and middle income country, we have similar pathology for COVID-19, but we have a different current crisis for the global inequity we know for before this crisis. And just this pandemic highlight the necessity we have to create and provide new opportunities to try to build this child healthcare better than we have now in the moment. And for pediatric neurosurgery specifically, how we can train again our residents, our trainees, and try to faster their learning curve. Maybe we can try to work with simulation. Cadaver maybe is costly, most difficult to have, but we try to build some simulation training and try to combine virtual reality, 3D reconstruction, and why not physical simulation, try to physical simulators to work with artists, hands-made, and try to build a new opportunity to have training without be with the patient. We have two different physical simulation to increase this learning curve. The pediatric neuroendoscopy simulator, and we have some pictures from the simulator inside the ventricles. We see some similarities with the anatomy we know very well when we are doing neuroendoscopy in the children's. And also we have the craniosynostosis simulator. The improvement for the next step is not only have a general simulator for scaphocephaly, but each patient have his own simulator based on his own specific pathology. We got the privilege just before the pandemic situation to have the World Federation Hydrocephalus Symposium here in São Paulo. Thanks a lot for Professor Concesio Di Rocco and Maurice Schooks that was with us. These simulators have already the approved quality assessment for neurosurgical training, and there is some papers on this subject too. And now is a different time. We try to prepare this surgical procedure with medical students. We try to keep some social distance, but we see here is not for all the time that social distance are keeping on. And for us, what we learn for this pandemic situation. We need to be resilient, not ourselves, but all the healthcare system. Try to keep the integrity of science. The global health institution need to work together with the physician, the scientists, and try to keep our empathy and try to improve equity in the planet for our children. Just for our take-home message, maybe we need to think about and to help the manager to reallocation on economical resource, if needed, simulators to improve and to increase the neurosurgical training, special pediatric neurosurgical training, and is maybe the safe manner to lower the risk in the operating room with our patients. This is the most similar draw I found to our life planned for 2020 and what happened with us and with our patients, with the planet. And just the final message, it's from Buddha, it's not from myself. What you think you create, what you feel you attract, what you believe become reality. As for our doctors, it's very important to take place for our patients, for our trainees, and try to still with them and do our best for the next step. And thanks very much for your attention. My special thanks for my mentor, Professor Schutz. And if we have time, I'm here. Thank you.
Thank you. Thank you very much, Professor Zanon. That was a very good overview of the challenges. I think in Brazil, you have had the winter during the last 6 months. I would think so in the Southern Hemisphere. Have you had the combination of the COVID as well as, do you usually get the winter flu in Brazil?
Yes, we have the winter time. It was more in the south of Brazil. The wave became when here in São Paulo is the epicenter of the pandemic situation. We was almost in the middle, and the south. My family live in the south. No one patient until the winter came there. And but fortunately the winter came when they was already prepared, because they see the situation here and the people taking care and was prepared. Fortunately we don't have the overwhelming situation like we saw in Italy at the beginning.
Questions for Professor Zanon from the panel or the audience?
Nelci, very nice talk. Rick Boop here. I just wanted to know, with the trainees not having access to the case volumes that they're used to, do we need to modify the timing, the length of time they train based on this pandemic, or do you think they can still finish in a normal time?
Thank you very much, Boop, for this question. Is unsolved at the moment. In the Brazilian society, we are discussing this subject. The trainees think that it's better just end like that for the beginning of the next year and just move on. But we are not sure what kind of examination we can do or improve to see if we have this real gap to fulfill in the next month. One of the suggestions is try to combine for the first 3 months for the changement of the residents group, try to keep them for a while and try to see how we can improve their knowledge. We have both situations in some countries and some cities. The resident was sent to the COVID pandemic intensive care unit to learn and to help. And in others, they stay in the urgency rooms. But even in the urgence during 3 or 4 months, it was not enough case for continuous on neurosurgical training. But I think we don't have closed this answer, Rick. And even for the exams, I saw the Indian Society of Neurosurgery doing exams by Zoom online, discussing patients, and open for the trainees and the examinators online. I think we need to be prepared for change our paradigms for the next step. But I don't have the answer. I would like to have your opinion if we have time to discuss this subject, Rick.
Well, I hope that things pass quickly enough that our residents may lose what would have been a year of research or elective time and still have enough core experience that they can graduate on time. But I think it depends on what happens in the next year.
Yes, true.
Thank you very much, Professor Zanon. I'll be, just one question before we move on. I know that you have a big practice. How much of the elective practice and how much of the craniofacial practice is happening? What percentage of elective practice and what percentage of craniofacial surgery practice is happening in your institution?
At the moment, we just start in August. We still 3 to 4 months without any one case on craniofacial. Which was just urgent cases. And we stopped doing craniofacial for this moment.
Wow.
We just start in August.
Thank you. Thank you very much, Professor Zanon. We will now move on to Professor Morota. Professor Morota is one of the leaders of pediatric neurosurgery around the world. He was a past president of the Japanese Society of Pediatric Neurosurgery and was the founding director of the Tokyo Women and Children's Hospital Pediatric Neurosurgery Department. He's now in Kitasato, and it will be wonderful to hear what's the Japanese experience and whether there's anything we can learn from them. Thank you, sir. I'll just get the microphone. Just a second, please.
Yeah.
Yeah. We can hear you.
Okay. One moment.
That's okay.
You see my slide?
Yes.
No?
Yeah. We see part of it.
I can't see my. I can't see my slide.
I can see part of it. Shall I put it from this side, Prof. Morota? I can share it from this side. You have already sent it to me.
Yeah, I try to.
Good. Oh, that's better.
I just can't see. Something wrong about. Sorry.
Just
I can see I can see only the speaker.
Okay. What I will do is I will share it from my side, so you can tell me to move the slide. Then I will move it. Is that okay?
Let me see.
Let me see.
Yep.
Oh, yes, we can see.
The problem is I can see the something happened.
Okay, Prof, I will do it from this side if that's easier.
Yeah.
Okay.
Oh, okay, one moment. I think now I can go.
Good. Yep, that's brilliant. Okay. That's great. we can see your slides. That's fine.
Okay, one moment. Did you see my slides?
Yes, that's good.
Okay, let me start. Okay, sorry. Okay, I'm talking about the pediatric neurosurgery and COVID-19 in Japan, but I'm not sure how much I can tell you because the situation in Japan is very special. And so today I'm going to talk about the COVID-19 in Japan and time course of COVID-19 and what makes Japan different from other countries. So something wrong.
It's on the presenter view, so you have to click on.
Here I have
Maybe
animation.
you can click just top bar beside the printer image.
So,
Prof Morota.
yeah.
I'll get that from my side. Then you can tell me to share. You can. If you tell me next, then I can move it. For
Okay. No. Could you see my slides?
Yep.
Okay. So okay. So first, I'm talking about the COVID-19 in Japan, and then impact of COVID-19 for pediatric neurosurgery in Japan. And I asked several hospitals in Hokkaido, one in Hokkaido, and two in Tokyo, and one in Osaka. And as I said, I talk about the role of JSPN during the pandemic. Sorry. So this is the situation of COVID-19 in Japan about a week ago, and the cumulative number of patients is 55,000, and every day about 1,000 patients is increasing, and the cumulative number of deaths is 1,100. So about 10 to 15 people die every day now. And this is the number of patients new and critically ill condition in Japan. And this shows the number of patients, newly diagnosed patients in Japan. And this blue shows the number of patients in Tokyo. And if you look at this graph, it's quite sure that we are now in the middle of second wave. However, the government doesn't acknowledge the second wave because the condition of the patient, the number of condition of the patient or the seriousness of the patient is different from the first wave. And here, this is the time, April 16, the government declared the emergency, but there's no lockdown. The government just asked us for the self-restraint. It's not order, just they asked, but most Japanese follows the government request. And this is the time the declaration was off, but still we are asked to ask the self-restraint for the social meeting, to go out, stay home, everything in the life. And this is the time in the middle of June or July that the government started the Go to Travel campaign. This is Japanese English. And what it means for economical reason, government recommended the domestic tourism for the people. The people call it Go to Travel or Go to Hell. And this is the age distribution of the patient. And during the first attack, the more people over the elder person has influence as the first wave. But in the currently in the second wave, more young generation, young people suffered from COVID-19. And this is the age distribution of 100,000 people in Japan. And this is the time of the August 12, and young children less than 10%, and teens are 20%. No, I'm sorry, 9.5 per 100,000 population, and the teens are 20, about 20 per 100,000. And if you look at this, this month, this is a newly infected patient, 100,000. And this is the data between August 4 and this week. But infected by COVID-19. Japan team better than other countries despite recent increase due to the second wave. This is my question. But what the problem in Japan is, this is the number of PCR tests per 1,000 people per day, and averaging 7 days. And this is the United States, Canada, Singapore, Germany. And you see, this is Japan. So small number. So what we can say is definitive lack of the absolute number of PCR tests makes precise estimation of the pandemic difficult in Japan. The reason why, most likely the government hate to test PCR because they think it's shame of Japan, something like that. So the only the people who are highly risky or highly suspected for COVID-19 can take PCR test. It was the time of April and May. And now the situation is slowly changing. Every medical center try to test by themselves, and people are more try to go to PCR test, and the government are now moving slowly to have more PCR tests in the country. So this is data obtained from the National Center for Child Health and Development. This is the largest medical center in Japan and founded in 2002. I was here from 2000 to 2014. And this is a total number of surgery, and this white is a neurosurgery. And this is the new patient in Tokyo. You see, this is the time restriction of the admission and surgery from the mid-March to end of June, International Center. And only emergency cases only were allowed to operate. But the emergency includes real emergency like hemorrhage, but tumor is also included for emergency cases. So the restriction of the number is mild, not so severe. And the family visit only one person for 3 hours a day during this restriction. And that means going to only one person were allowed to attend during the during this restriction. And this is the number of surgery, the change of the number of surgery. And this is during the restriction time, and basically the number is not so high compared with Western countries. Even I was there, operate only about 40 cases a month. But there is some influence maybe. And this is the inpatient and outpatient also have some influence by restriction. But the reduction, this reduction is very limited. And influence of COVID-19 did have some impact, but not so serious compared with other countries. This is my impression. And this is another data from Tokyo Metropolitan Children's Medical Center. This is the second largest pediatric medical center in Japan. And I was there from 2014 to 2018. And they had their own phase, Tokyo Metropolitan Children's Medical Center phase. Phase 0 is this is a normal, and phase 5 is very dangerous condition. And the party says that like a new condition like New York and Italy. I'm sorry. And they decided this phase 3 at the time of the emergency declaration from April 8 to May 17, and then moved to phase 2, phase 1, and phase 0, the normal, in mid-June. And then again, after this regrowth, increase of the COVID-19, the phase moved to phase 1, and in August 11, they declared the phase 2. And based on this phase 1, 2, 3, 4, 5, they asked the surgeon and the those tests for IGAD or the double globe technique or apron gun or N95 mask. And they decided everything, how to do, how you use double globe or something. In phase 2, you use a double globe or something. And this is for surgeon, how they wear the IGAD or the N95 mask during the surgery or something like that. This is also the how to use outpatient clinic or admission. The hospital employees have to obey for the conference should be less than 30, less than 20, less than 20, and no conference only for team. And you know, the surgical mask you have to wear in the hospital, and even in commutation, you have to use mask in the train or in the bus. And this is the number of surgery in Metropolitan Children's Medical Center. This is the time of declaration, phase 3. And so there's some restriction of the number, reduction of the number of patients, and the in and out patient average here, they also dropped. And so tight regulation based on the degree of COVID-19 pandemic is present at the Tokyo Metropolitan Children's Medical Center, and the reduction of surgery in and out patient. But these numbers are still limited. This is data from Hokkaido, and this is only one pediatric medical center in Hokkaido. This is the northern part of northern major island in Japan. This is a new patient in Hokkaido. They had the first attack here, then moderate. The Hokkaido is the only one area the local government declared lockdown during this first pandemic. This is infected and recovered. And this is a cumulative number of admitted patient. Okay, this is the restriction in the hospital. Restriction in clinical practice from mid-April to late June, and only limited influence by COVID-19 in this hospital because the hospital is not assigned to accept the children with COVID-19. Only university and the major city hospitals took care of the COVID-19 children in Hokkaido. Still, they restricted the number of surgery. Actually, the number of surgery doesn't influence so much here. And the Kansai Medical University, the Hirakata Hospital, this is one of the affiliated hospital. And this is a patient, new patient in Osaka. And they had the first wave and second wave now. And Sorry. And in this Kansai Medical University, the COVID-19 patients were treated at other affiliated hospitals of Kansai Medical University, not at Hirakata. So they don't have so many influence, but still, if you look at this data, this is the data both adult and pediatric cases, and surgery for pediatrics and tumor didn't differ from 2019. The green is the 2019 data, a number of surgery in 2019, and the white is 2020. But trauma, like chronic subdural hematoma and vascular disease, cystinosis, or the aneurysm, both decrease in number. And restricted activity in life influence maybe. And outpatient number, and especially pediatric, dropped markedly during the declaration of emergency. This was reported from the doctor from Kansai Medical University. So during this pandemic, what we did here as a JSP and Japanese Society for Pediatric Neurosurgery is we provide the news updated the news for the corona-related information. And we also provided these papers from General Neurosurgery and other journals. So the International Committee of GSP provided recent information about COVID-19 on the homepage, introduced the latest publication about its impact on the daily practice of pediatric neurosurgery in the world. And so in my summary, the COVID-19 does have a significant impact on Japan, but its influence in pediatric neurosurgery seems limited compared with other major countries, despite for handling by the government. Its influence on pediatric neurosurgery is also differ between hospitals, when they're located, and how the local government manage COVID-19. And so generally the body temperature is checked at the entrance, and PCR test for surgical patient, and limited hospital visits by parents. And we are asked to wear masks in the hospital, and we are asked to take social distance in and out of the hospital, and also the self-restraint in the private lab. Even after we finish the hospital work, you have to stay home or try not to go out for social activity. And pediatric neurosurgical practice is returning to the baseline in Japan, and even in the midst of the second wave of COVID-19. However, the future is unknown and unpredictable because we don't know the exact data about the infection of in Japan because of the lack of PCR tests. Yeah, thank you very much. I'm sorry for my trouble for presentation.
No, not a problem. Thank you very much, Professor Morota. It's great to hear that Japan is still, chugging along quite efficiently, even with the pandemic. Just two questions from me before I open to the floor. I know that you have a large interest in spinal lipomas, and how's your elective practice of lipomas? Are you able to do all those operations, or is that been curtailed? And the other second question is the schools, have they been closed early in Japan as well? I'll write it down on the side, Prof.
In my case, in April, in my hospital, we are asked to stop surgery except emergency cases. So I didn't operate a scheduled patient on April. And from May, after the government, from the May, we resumed at the beginning 20% of the case, and then 50%, 80%, and now return to the normal regular level of the surgery. Yeah, the school in Japan has closed in February and March, and up until June. And the school resumes from July, and they don't have enough length of summer holidays in Japan.
Thanks. Thank you very much, Professor Morota. For any questions for Professor Morota, could you please type it in the chat box, and Professor Morota, if you could please kindly answer for the reasons of the time. I will now move to Professor Tew, Seow Wan Tew from Singapore. I think Singapore had been certainly in the news when in the start, and I know I had once worked in Singapore back long time ago. I'm sure they are very well organized and coordinated, so it will be good to know what Singaporeans are doing. Thank you.
Right, thank you, Naren. Well, I don't think we did that great. And I'll tell you why, because I think that's really what actually happened. So, okay, let me just, can you see my slides now?
Yeah, yes. Yeah.
Okay. So actually, we know that the virus started in December 2019, and we already alerted about this in early January. We had our first confirmed case of coronavirus on the 23rd of January. And this was from a patient that was a tourist from Wuhan. And actually, interestingly, because of that, we actually had a very high number of cases also of China from the February. Early February, we had the highest number of cases outside of China. And of course, the pandemic was declared on the 11th of March. So I'll just quickly talk about Singapore's response to and recovery from the pandemic, because really this affects what actually happens to our pediatric practice and neurosurgical practice and actually hospital practice in general. So actually, we were already in a way prepared for one of these pandemics, because we experienced the SARS in 2003, and it was quite devastated. There were doctors, nurses who died actually. And so for the past 17 years, we actually had been doing preparations. The preparations would be a part of our government and healthcare institutions, business continuity planning, enterprise risk plan management as well. And then as part of that sort of planning, we actually had a National Center for Infectious Disease building that was built, and it was officially open. Luckily, if you think about it, in September 2019, this was a 330-bedded purpose-built facility for infectious disease management prevention. They had clinical services, intensive care, quarantine, isolation facilities, operating rooms, and of course, also for the testing of infections and so forth. So a PCR test was something that as soon as we got the genomics of the virus, we were able to start testing. And it became obviously the operations center for the outbreak. But at the same time, also the other public hospitals were also prepared for admissions for this. So if you look at what actually happened, we actually had a steady increase, and you can see that the number of cases increasing on a regular basis, right? We actually had a government form a task force to look into the issue. And then this DOSCON alert level was raised to orange. So what is DOSCON? DOSCON actually is something that was followed after the defense readiness condition, so what they call DEFCON in war. So we actually have DOSCON green, which is what in non-pandemic times, all right? Yellow when there's something starting to happen and we are concerned. And then of course, orange, which is what we currently are now, but not red. Red is, people are really, really dying. And the country's risk calibration and mitigation approach, basically, you have a lot of screening, target testing, extensive contact tracing, confirmed disease, combination of then what they call at one time quarantine or stay home notices, right? And then for high risk individuals, and then for people returning from high prevalence country, and then individuals identified through contact tracing. Then of course, it was a law. It became part of the law that if you're on quarantine or stay home notice, you cannot leave the house. Social distancing measures, and then we even had free diagnostic tests and treatment in hospitals for our local residents. And as soon as the hospital went into DOSCON yellow, we already had temperature screening. Hospitals entry points were controlled so that not every entrance can be assessed. And alert for travel history. In the early days, just China, and Wuhan. And then, of course, as the other countries started reporting more and more cases, then we had more travel alerts, right? And then patients with fever, respiratory tract infection, pneumonia, positive history were already separated from other patients as part of the initial screening procedure. And then, okay, there were things that the government also gave rise to tell us what we need to do, right? Clean hands, minimize contact. Even some of so this is a hawker center in Singapore where you eat food sold by salvage stores. Some of the seats were closed up with things here so that to say that you cannot sit there, so that this will reduce the number of people crowding, okay? And then wearing a mask. Now, early on, we were told that there's no need to wear masks in public because save the mask for those who need it, who are sick, put on the mask if you are not well to prevent infecting other people. Of course, in the hospital, we all had to wear surgical masks. And then if you were in respiratory wards, you would have to wear N95. And subsequently, the anesthetists realized that they also had to wear N95 masks when they're intubating patients and so forth, right? But then after that, there was a reversal of the policy. And from the middle of April onwards, everybody had to wear a mask when you're leaving home. And if you didn't wear a mask, you could be fined up to $300 penalties for not masking up. And then, so all these signs tell you what to do, where to wear your mask and so forth. And then even the government started distributing free masks to households. And from the medical point of view, what did DORSCON Orange meant? Well, basically, we all had to go for our mask fitting. So this is a name badge that I carry. I have prepared, each one of us had to at least be fitted with 2 types of N95 masks in case there's a shortage of one type. We are trained to use powered air purifying respirators. We are given eye shields and thermometers. So this is a thermometer I got, but then I just covered mine with the scanning one. So because we had to take our temperatures twice a day, and you had to be recorded, and you could be call up if you're not actually registering a temperature. We actually have a whole IT system, a form that you can fill up on your laptop. On your laptop or on your mobile phone, and that gets sent in. Right, then you have to declare if you're sick, and if you're sick, you have to go to the staff clinic, special staff clinic, and then there you'll be screened again. So basically, so temperature recording compliance was important and issues reminded. And under OSCON Orange, the movements of doctors across all were restricted. At the NNI where I practice, although I'm a pediatric neurosurgeon, most of the time I am at the children's hospital, but I do go to the adult hospital to do administrative work as well as run the clinic, usually mainly for patients that have been transited from the children's hospital to the hospital, so they get followed by the same surgeons, right? So basically, that was a no-no anymore. I actually was posted to the children's hospital and told to stay there, cannot move to the other hospitals and so forth. And then there was also, because we also are subspecialized in it in the adult side, they also had to look at who was doing the subspecialty like neurovascular, skull-based, neuro-oncology, and make sure that there's sufficient doctors posted to certain hospitals. And then because we're also serving the peripheral hospitals for trauma and so forth, so the department was divided up into various small divisions, right? And then we were still allowed to transfer some of the patients from one hospital to another, but only for neurosurgical treatment. Most patients were not allowed to be transferred from one hospital to another. All right, and then even before you transfer hospitals, you need to consult with the ID physicians to allow them to come in, right? And of course, in the adult side, especially because all the beds, ICU beds and all that were being saved for cases that are going to get worse, elective surgeries were put on hold, and then any surgery that was going to be done had to be reviewed. Non-cases, urgent cases postponed, but semi-urgent cases proceeded on. And then realizing that there could be an unavoidable backlog of elective cases, these were reviewed. The non-urgent cases were reviewed weekly, and then some of these were tried to be given some priority if and when there were available beds, right? Because the hospital also restricted the number of cases we could do and the number of ICU beds that we could use. And then basically endonasal surgeries were cancelled unless they had COVID testing done. And the recommendation subsequently was to actually have 2 negative tests before you allowed endonasal surgery. Outpatients basically were reduced to at least 50% or even less, because some patients also did not want to come to hospital. So many times they call up to postpone, and we gladly postpone them. And then we also were screening patients to make sure that if the appointment is not really urgent, we will postpone them again, although we know that there's going to be a backlog. And then patients who had scans already performed, the scans were reviewed, we will actually initiate phone consultations, and also started doing some degree of some small numbers of teleconsultation using Zoom. Right? And the pharmacy system in the hospital, basically they started delivering medication home so that patients didn't have to wait in the outpatients for the clinic. Our own departmental meeting, basically because of the restriction of inter-hospital movements, we moved initially to WebEx, then of course subsequently to Zoom, because the Singapore government did not really want us to use systems. Because Zoom actually, from Singapore, you had to go to the US and it comes back. So there was some concern about patient confidentiality and so forth. So all our departmental meetings, M&Ms, lesson tutorials, and journal clubs were done at by Zoom. And then this is, you could still gather together in the room, but only less than 5 at one time. And this is one of some of the meetings where, some of us will be at home, some of us in separate offices, and this is the main meeting room. Now, everything seems to be okay. So early stages in Singapore was being praised as the world leader because of our claimed response to this crisis. But then somewhere along the way, we lost our grip on things because the number of COVID-19 cases started to increase. And this had to do with the condition of foreign workers living in Singapore. Because towards late March and April, the number of clusters detected at what they call multiple purpose-built dormitories for foreign workers, we had about 230,000 workers living in 40 dorms, started to increase. So they contributed overwhelming proportion of new cases, right? In fact, we then started to become the highest number of confirmed cases in Southeast Asia, although in the last few months, we've been taken over by the Philippines and Indonesia. And our lockdown was announced on the 3rd April and then extended to 1st June. So if you look at what actually happened, is the chart I showed you the initial slow increase, all right? And then suddenly from April onwards, you could see, right, the total number of cases, right, going up every day, okay? And these were the infections that were related to the foreign workers. And so when you look at this chart, which was say sometime in May, you could see that, so what they did was so this is in the community, because once the patient, the dormitories and were identified to be various clusters of infection, they were all quarantined off, and then they started checking. So this is what's happening in the community, right? Actually a small number, but you see what's happening in the dormitories, right? Was amazing, right? So dorm residents were getting it. And why? Because, so a lot of these low-wage migrant workers coming to the country, many of them are from Bangladesh, India, some from China, Malaysia, and they do construction, maintenance, and manufacturing. So there are 43 mega dormitories, each with more than 1,000 workers living there. There's some 120 factory converted dormitories, typically housing 50 to 100 workers, and then temporary living quarters around 40 workers on various construction sites. So these are some of the purpose-built dormitories, right? And they were actually quite cramped, maybe 12 to 20 people living in packed room ventilated by small fans attached to the ceilings or wall. They sleep on bunk beds. The hundreds of men on each floor shared communal toilet showering facilities, and the rapid spread would likely lead to them socializing across dormitories on days off and so forth. And because although they stay in dormitory, they all do not work in the same construction site. They could be put there by the companies, but they all work in different construction sites. And because if they don't go to work, they may not get paid. Many of them still go to work when they're sick. And so this one just keep going on. And so the first dormitory cluster identified in March, right? And then subsequently in this dormitory went on to 2006. So 60% of cases in Singapore, all right? And you can imagine that Also, what our government did was to lock down all the dormitories with known clusters. They were gazetted as isolation rooms. Workers had to stay in their rooms, and then meals were actually prepared for them, and they didn't have to cook anymore. And then the testing of the 7,000 workers a day started to identify and then isolate those. And then those that were tested positive were isolated. And so this was applied right across, even to all those dormitories that did not have clusters. And then obviously there's not going to be enough space for them to stay. And so we had to even use military camps, exhibition centers, floating hotels, empty housing block, private apartments, and each location had its own on-site. And some of these patients who were really sick, actually they were also given pulse oximeters to check. But the thing about this is that most of these are young patients, that they were between age of 20 to 40, majority of them. And so, you know, their symptoms were actually not so bad. Right. So what the government did was, as soon as the numbers started to increase past the 14,000, they start to have different isolation facilities. So they have community care facilities for those who tested positive and no symptoms, community recovery facilities for those who actually remain well. Some of them are hospitalized. When they're well, they'll stand out. So the hospitals were not so crowded. They even have swab isolation facilities for those who are waiting the test results, and then before they were either sent to the clean or the infected cases. Then there's dorm isolation facilities. Now, obviously, the number of medical workers, healthcare workers, nurses, doctors to these areas had to increase. And so what happened was then many of our junior doctors were taken to go there because there weren't enough doctors and nurses to cover them. So when you look at what actually happened, right? So this is, one of the latest charts I showed. So starting from June, you can see the number of foreign workers. There's a peak here because there's just increased one of the final tests before. Now it's starting to come down, right? So our number, and then you see the number of cases what we call in the community, meaning among people who are outside of the dormitories. Actually, the numbers are actually very small. Right? And so even on the 18th, so a few days ago, you know, they said that actually 100 cases have been detected in the dormitory that were given the all clear, right? So 7,000 more workers are now being quarantined. So actually a lot of workers are being quarantined or isolated. They're not going back to work. A lot of the economy is really, things are not moving, houses not being built properly and things like that. So although say 3 days ago, all dormitories are cleared, right? But basically only about 86% of the workers actually have been allowed to go back to work. So really that was the big flaw. So, you know, it was something that was not thought of enough, you know, when they had when Singapore did the, preparations, they forgot about the foreign workers, which was actually something very sad. But it's something that we need to think about. Also, busy areas where there's a lot of people living closely together, and even nursing homes are one of the things that we need to think about. So our circuit breaker was initially supposed to be 1 month, but then it increased to another month. And then during that time, only essential services, food establishment, you cannot eat there. You can just buy food to go back, supermarkets and clinics. Schools were closed, and then the school holiday was moved forward by another month. So now in August, end of July, early July and August, the children have gone back to school, right? So these are some of the things that you are allowed to do and were told what you should do and what you should not do. Nice pictures always. Then we had the phase 2. Again, they open up more things, but not so much. So safe distancing, excuse me, still there. And then the small group of gatherings, only 5. During the lockdown, you could not visit your relatives, right? Only households to stay in a house, but now you can, but not more than 5 people. When these are lists of the activities that can be resumed since then. So basically, we are still asked to telecommute if you can. So many of my secretaries are all still staying at home, right? They do work from home arrangements, all right? And then basically monitoring health and evacuation. Still no physical meetings, no socializing. So imagine in the last 3 months, I've eaten out of my house only 3 times and 5 months. Right? And then we don't have planning events. So obviously the IFBN that was meant for October IFBN meeting had to be cancelled, right? Things to do when you are not well. And so from doctor's point of view, temperature reporting twice a day. Every building that you go into has one of these safe entry QR codes that you need to scan with your phone, and then that's sent. And then when you leave the place, you send again so that they can do contact tracing. We are asked to do a trace together app on our phones so that in case they're near, they can check if somebody is infected. So these are one of the examples of QR code that you have to scan in to go into a place. Our outpatient clinic, also we had one parent per child rule, so not everybody could go in. All right, whether we had to have workflow for suspected. So someone comes to the outpatient clinic, if they're found to have a respiratory infection, they are sent to a separate area. Right, they have stickers for all these patients who are coming into the hospital. You have outpatient designated isolation room, so that when you go and see a patients that are infected are sent there, and we dress up with the PPE to go and see them, and then even check these for screening of admissions. All right, even our list, you know, are restricted to 4. So you go into a lift, right? If it's a small lift, you can have 4 persons at any one time. And so the inpatients, you need management plans for suspected cases, checklist of screening, and then response plan for confirmed cases, and then what about patients who pass away? Luckily, in the children's hospital, actually we had less than 100 patients with COVID because the number of children infected was very small. But we still have to wear surgical masks in the ward clinics, even in the offices, and you wear N95 full PPE only in special situations. Actually, even during the lockdown, the number of elective surgeries, we were not doing elective surgeries, but a lot of the surgeries were mainly semi-emergencies or emergencies. And basically for the last 2 months, actually we've been business as usual again, right? But of course, less travel across the hospitals, even though we can go. And I've been to another hospital to do some shunts for some old patients, right? We still have meetings and teachings about Zoom, and OC travels by us, for us, medical staff are still restricted. We don't know when, probably end of the year, right? And there are a lot of signs there inside the hospital, say keep healthy distance and so forth. So finally, if you look at what actually happened, this is a picture. So in May, this is what you see, starting in January. In May, so you see a sign rise in the number of cases in Singapore, right? By August, we're kind of coming down a little bit, all right? And I think the control of the DOMs are much better compared to what actually happened in May and June. And so currently, Singapore, we have 56,000. We're probably third on the list of countries in South Asia, but we actually have only 27 deaths. And a large number of patients actually are not in the hospitals. They're actually in those community care facilities. So thank you. So this is just a picture of what actually has been happening in Singapore. So we ask you to stay safe and stay at home. And of course, hopefully we'll see you in 2021 for the ISPN, which is going to be combined with the IFNE meeting. Thank you very much.
Thank you very much, Professor Tew. That was a very comprehensive talk, and certainly Singapore has gone from ups and downs, but I know that it's a country that's well connected and will respond quite nimbly. Before I open the questions to the floor, my question is in terms of in Singapore, when I was there was quite a healthy private neurosurgical practice. Has the private neurosurgical practice been affected drastically by this, or is it still going?
Oh yes. Actually, during the lockdown and during DOS1 Orange, at least the first part, so that for two and a half months, there was no elective surgery, even in neurosurgery. So all the private hospitals actually had to stop doing elective surgeries except for emergencies, because they were also taking some of the COVID patients that were being, so the patients, if they are quite serious, they stay in the government hospitals and even ICU. But once they recovered, they are quite well, and some of them are very, very little symptomatic. They actually were sent to the private hospitals as well, because the private hospitals were empty, and obviously they were they were losing money as well. And so the government actually sent some of the patients to the private hospitals as well. Not the very ill ones, but those that were recovering.
Thank you. Questions for Professor Tew? How come, Professor Tew, that I'm delighted that there were only 27 or so deaths from COVID. What was so effective that you guys had such a small proportion of deaths for such a large disease rate?
Actually, it's hard to say. I think maybe our patients come to hospital much earlier. Of course, if you look at the actual numbers, a large number, more than probably 80%, were actually younger people because the foreign domestic workers, foreign workers living in the dormitories, they were in their 20s, 30s, 40s. So they are not the age that get very sick. I mean, we had patients that stayed. We had a 101-year-old lady that stayed for 2 months, 1 month in ICU, and she survived. So I think most of our patients do come to us early. They are detected very early, because as soon as this pandemic is there, I mean, we have had, so after SARS, we had bird flu, we had Ebola, we had MERS and so forth. So all the clinics, everything, they're all on standby, temperature checks, history of respiratory disease, and basically all the screening procedures are there. And if the doctor who's seeing them, whether it's a GP or a polyclinic doctor, once you are thought of be possible candidate, you are actually sent to the Center for Infectious Disease for checkup, for testing and so forth. So, very, very vigilant. Ambulance will be there to bring you there. You didn't even have to pay a single cent. So I think the pickup of many of these patients who were there, and most of them came early. We actually had one patient who flew in from Indonesia because he probably had COVID and he knew it, but even then, when he came, he was actually in a very bad state. He actually passed away as well. So, we also had patients that passed away, but I think most of our patients were picked up very early.
Thanks, thank you. Any questions for Professor Tew?
Yes, Professor Tew. Congratulations.
Thank you.
Well done in your country.
It's not me. It's not me in this country.
Yes, it's all the people together. We do a mistake at the beginning because it was tell us that maybe you need to go to the hospital when you are in respiratory distress, and maybe it's too late. Your protocol to send the patient to the hospital, it was based on testing or on symptoms?
No. So screening, and then
Yes.
if there's a suspect, you send to the NCID for testing.
Okay. Some treatment on the protocol if they test positive, or only symptomatic?
Yeah. So the moment they get tested positive, they're admitted to the hospital. Now, initially it was the NICD, but then you see all the government hospitals will take COVID patients, and then they were treated according to what the protocol is put up by the ID specialist in the hospital. And then not only that, the moment you identified as a positive test, contact tracing starts. So they will go and find out who your relatives are, and then or people you've been in close contact with, and then every one of those will get quarantined or stay home, compulsory. Okay. So that's how you control the thing. I mean, it's something that we learned from SARS. The only difference, I think, between SARS and COVID is there are many, many COVID patients who are asymptomatic, or or symptoms are very, very mild. So that's the difference, and that's why it spreads so much faster. And then, of course, it's also said that patients with COVID, you might actually start spreading even before you become very symptomatic. Whereas in SARS, you became very sick after you got infected. So,
thanks. Professor Tew, just one question from me, if that's okay. In terms of if you had covered it on the talk, so I apologize. How much of what percentages of your elective practice is now back? Pediatric neurosurgery.
Virtually back to normal. We're doing some craniofacial cases. I'm doing some of my lipomas and stuff like that. I mean, we don't have a lot of patients, but So we still have our elective list that we use, although because of the shortage initially, we had this 3-day or 5-day rule where, if nobody is there, if the OR is empty, you can actually book it 5 days ahead.
Thank you very much, Professor Tew. It now gives me great pleasure to invite Professor Chatterjee, Sandip Chatterjee from India, from Calcutta. He's also the president of the Indian Society of Paediatric Neurosurgery. Thank you, sir. It will be great to hear how things are in India and what's your plans for the next 6 months. Thank you. I'll just unmute you just a second.
Are you able to see my screen?
Yes, we can, yes.
Okay,
Thanks.
great. Right, so I am going to look upon this a little bit differently because of 2 reasons. Number one, I'm going to limit myself to our experience with pediatric patients only, number one. Number two, I am not in a position to share data about India because India, as you know, is not a country, but a continent. And in this short period that I had, which was about 6 days or 7 days, it wasn't possible for me to try and get information from across the country. So this is going to be a more personal look at the problem and my own learning experience of this pandemic. And it's lovely to see everybody, including Nelci. Hi, good evening. And nice to see you, Naren.
Thank you.
You asked us to talk about response, recovery, and preparedness. And I thought I'll tell you how India has scored in these 3 categories. If you look at response, I think as a country, our response was very poor because we had a lot of problems in India. And I don't think that you want to go through the details of that. But we had a lockdown, which was one of the longest lockdowns, one of the best enforced lockdowns. But we had a lot of migrant workers who were in different parts of the country. When, as the lockdown was lifted, they traveled from one part of the country to the other. They were living in terrible conditions. So most of them were infected, and they spread the infection right across the country. About recovery, well, I think we scored 6 out of 10 in terms of our recovery, in terms of our neurosurgical facilities. And preparedness for the future, I think we will probably score a little bit more. And I'll share with you over the next 10 minutes why this is so. First of all, you must understand that India is a land of contrasts. We have gas delivered in vehicles drawn by cows, and we had dual carriageways where we have cows. We also have people like this. And don't think that he owns a Jaguar and he owns a Range Rover. He doesn't own either of these 2 cars. He neither drives either of these 2 cars. He owns both these companies. So, we have hospitals that are very, very well equipped in India, both government and private. And then we have hospitals which are very poorly equipped in different parts of the country. So because of this, we've had a lot of problems. Number one, when the pandemic started, nasopharyngeal swabs, PCR for COVID-19 was not available in many parts of the country for the first month or month and a half, including in my own city. It wasn't freely available for a month, month and a half. The other thing was, so we were left with no other option but to use a high-resolution CT scanning of lungs as a mode of screening adult patients with COVID-19, because as you know, this is a very good screening tool. Question was it ethically correct to subject children to an HRCT of their lungs? The other question we had was, under what age was HRCT inappropriate for children that were being screened? So under what age should you not do a CT scan? The other problem we had is there are many operating theaters in India which do not have warming blankets or bear huggers. And the operating temperature has to be kept pretty high in the operating theater when you're operating on small children. And given that you had to wear PPEs, and double-layered PPEs were worn by a majority of my colleagues up and down the country, it isn't a pleasant experience to wear a double-layered PPE when you have the operating theater ambient temperature high. because the child is very small. And finally, we had a lot of problems because it wasn't possible in many parts of the country to have separate pediatric and adult isolation wards. This was not possible geographically with the same hospital. In fact, it was even in the hospital in which I work, which has an adult block and a pediatric block, it was not possible to have two separate isolation wards. The other problem we had is that, you know, India has a very federal structure, so different states have different laws. And in, for example, the state in which I work, which is in Bengal, which is where Calcutta is, the government decided very early that there would be separate COVID and non-COVID hospitals. So we were a recognized non-COVID hospital, which meant that if we had any patient that turned out to be positive, we had to do emergency treatment, but then stabilize them and send them to a COVID hospital. And that causes problems of its own. And you know, this is only one layer and you wear another layer of PPE, which is sterile over this. And if you have to work in a small district in India where you don't have good air conditioning in the operation theater, or the air conditioning has to be turned down because it's a child, I think it's a torture for a lot of surgeons. What are the problems that are peculiar to the pediatric population? This is across the globe, but definitely we have gone through this in India. Initially, we thought the children were rarely affected. Later, we learned that was not true. The other problem is that in most places, mothers stay with the children in the wards. So it's not enough to screen the child, you have to also screen the mother. The third problem was that in all hospitals, we had transition wards where untested children were admitted. But the problem was that most of these transition wards were located in the adult wing of the hospital, which meant that sometimes you had combined pediatric and adult transition wards, and the children were forced to be admitted in an adult transition ward till their results of their COVID-19 tests went on. I need to tell you here that across the country, the average time it takes to get a report of a COVID-19 PCR from a nasopharyngeal swab is about 24 hours. So these children have to be kept in transition for 24 hours. The other thing is, across the country, because of guidelines that the Neurological Society of India laid down very early in April, we were asked to do 2 nasopharyngeal swabs before doing any form of semi-elective or semi-emergency, if you like, surgery. The question was whether in children you needed 2 swabs, because the pickup rate in children is much higher, and I'll share that with you from the literature. The other question was, what about neonates that need urgent surgery? Should one wait and test when you know it takes 24 hours, or should you operate on neonates immediately? Again, knowing that the incidence of COVID-19 in newborns is very low across the globe. And finally, the question was, is it correct to delay semi-elective surgery in children, say, for example, with a brain tumor, given that even if they do get a COVID infection, they have excellent results. And so if you have an adult and you do a brain tumor surgery, and post-operatively in the first 2 weeks or so, they get COVID-19, we know the mortality is very high. We know that that is not true for children. And therefore, is it right to withhold semi-elective treatment of children, unlike the adults? And this is one of the largest systemic review of pediatric COVID patients. And what they showed was this, which is that the pickup rate from a nasopharyngeal swab, you know, the CT value, the amplification cycle threshold, you will see is much lower in children below 5 or 5 to 17 compared to adults, which means that your chance of picking up a positive PCR is much higher in children below the age of 5. And this is why for children below the age of 5, we decided we do not need 2 nasopharyngeal swabs. How has it changed our practice? I told you I'm going to talk more on a personal note than on a national note. And here's a child who was a 10-year-old who came to us very early in the pandemic with a grade 3 paraparesis. This is a child with TB of the spine who's recovered from the TB, but thereafter developed gradual paraparesis, came with 3 to 4 power. A parent said that was the power for almost 2 months. So this was, in our practice, did not constitute either emergency or semi-emergency surgery. So we told the child, okay, you can go and wait and let us know if the power deteriorates. Unfortunately, in India, what often happens is if you tell the parents to go and wait, they take it very casually. They came back 3 weeks later, the child had almost grade 0 to 1 power. This was what the MRI showed. And then, of course, we had to do an urgent admission. We did do a COVID PCR and ended up doing a very major surgery. But perhaps we should have done it when the child first presented. The results were not good, and today, almost 3 months down the line, the child's power is about grade 3 and has not yet improved beyond that. So this is the other problem that we've encountered. Here's a patient that I've seen operated on just a fortnight ago, a 4-year-old who came with severe headaches, vomiting, and drowsiness, and deteriorated while admitted in the hospital. COVID-19 status was not available, so we had to do something as an emergency. So normally what we would have done for this child who's deteriorated rapidly is to put in an external ventricular drain and do the posterior fossa tumor in one sitting, leave the EVD for 48 hours and then take it out. But in this situation with the COVID-19 status not known, we ended up doing what we would have done 20 years ago, which is we ended up doing a ventricular peritoneal shunt. Because I thought if this child then tests positive, then remember by regulations here, we would have to send this child to another hospital, which is a COVID recognized hospital. And that would be difficult with an EVD. So we had to do a shunt. And fortunately, this child tested negative. And then 2 days later, we went and did this medulloblastoma. Here's another very sad story of a 5-day-old neonate that was transferred to our hospital. The mother was COVID positive, the father was COVID positive, the child came with a bulging fontanelle, labored breathing, and we tested and the child was also positive. The 5-day-old neonate was also positive. And of course, according to regulations, we could not do anything. We tried to do a fontanelle tap, it was almost impossible. We had to send the child to a COVID hospital and the child died during transfer to the COVID hospital. Not only have we had the problem of, from the pediatric neurosurgical side of having difficulty in doing quick response surgery, but patients themselves have presented very late. And here's a 7-month-old who was referred to me when the child was 1 month old with this dorsal dermal sinus, and ultimately waited 3 months till the child was paraplegic, grade 0 power in the lower limbs, before the parents came to us. And you can see there's an intramedullary abscess from that dermal sinus. And we really had to do a cordotomy and let out pus while doing the dermal sinus tract, something that we would hardly ever have to do in the world today. And this is another terrible story of a 7-year-old who had seizures, was referred to me end of March. The parents were too scared to come. They didn't live in the city, they lived outside. They heard these horrendous tales of people just falling down dead in the city with COVID, so they didn't want to come into the city. They lived in a district outside in the rural area, which was hardly affected with COVID. In fact, there was no COVID cases in their district at all. And they waited, and they eventually came to us in the first week of August with a tumor that is horrendous, and as you can see, occupying almost all of the brain. And this turned out to be a glioblastoma, but the results were very unsatisfactory, and the child is very much hemiplegic and not at all very well even after the surgery. So, you know, this has really been a big problem in India because patients have been very scared to go to hospitals. And I think there has been a transition in the middle of June. Between April and June, most of the neurosurgeons were very reluctant to do too much of sort of semi-elective surgery. They were deferring the surgery. And then by the time we realized this was something that's not going to go away in a hurry, we have to just carry on and do whatever we were doing before. Patients and their parents became very weary of coming to us. And we had very, very late presentation of these children. I talked about infants and of neonates, and this is a very interesting paper which shows that there were only 25 neonates affected by COVID reported from the Wuhan paper. And it is extremely rare, and almost certainly the transmission is horizontal and not vertical from the mother. So this is the policy now we have adopted, and this is what we do. For neonates, all our neonates and newborns are admitted in the normal neonatal ICU, no isolation in ICU. If they have an open neural tube defect or something like that, they're operated immediately without any COVID-19 reports. Other cases have a swab, we get the report. In our hospital, we generally get the report between 14 and 16 hours, and we then do the surgery. Patients are kept post-operatively in the NICU. No rooming is done with the mother until we know that the mother has got 2 COVID-19 reports are negative. So the mother has 2 swabs taken on alternate days. If they're negative, then only if the child is fit, the child is roomed in with the mother. For children below 4 years, this does not include the pediatric intensive care admissions. They're admitted in a pediatric isolation ward with the mother or a caregiver. Both mother and child have a chest X-ray screening on admission. They both have, the mother has an HRCT lung, and both have nasal swabs for COVID-19 sent. If they're negative, then they have the surgery. Mother has a second PCR after 2 days, and post-operatively, the child goes to a normal pediatric ward with the mother, not in the transition ward. And in India, parents like to keep the children in hospital till you remove the stitches because they come from very far away. We have been encouraging them to leave very early because even inside the hospital, there is a risk of getting COVID, or there was in the worst period of the pandemic. For children over 5 years, they're admitted in an isolation ward. Both the child and the mother have an HRCT on admission. Both have nasal swabs. And then, of course, the rest is more or less the same. For emergency admissions, all are admitted to an isolation neuro ITU. Now, we cannot have 4 ITUs in our hospital. So a normal adult, an isolation adult, a normal child, and an isolation child. So we have one single isolation ITU, which has an adult and a pediatric wing. Emergency surgery is performed. These patients are admitted. They come through a separate door, go up through a separate lift to the isolation ITU. They have separate ventilators. They have a separate corridor. They go up by a separate lift to the operating theater. And there's a separate operating room in the theater completely sealed off from the rest where they have the surgery. Again, the swab is sent before surgery. If it's negative, they go into the normal hospital or ward and go into the normal PICU. If unfortunately any of them test positive, then of course we are not allowed to operate on them in our hospital. We have to stabilize them and send them to a COVID hospital. So today we have classified our surgeries into these 4 types: non-essential elective, like craniosynostosis; essential elective surgery, like say an LDM or a lipoma; essential surgeries like brain tumors, and emergencies, of course, like open neural tube defects or trauma. So what has happened is in our practice, some things have changed. Untested children have only the emergency surgery performed. So if you have a posterior fossa tumor, you're deteriorating, you get a shunt. If you have hydrocephalus with a spinal dysraphism and you're deteriorating rapidly, you get a VSG shunt. Acute hydrocephalus, we do a VSG shunt, wait, get a negative test before we could do either ETV or a ventricular peritoneal shunt. Initially, no high-speed drills, no endoscopic procedures were performed, but now gradually we've started doing endoscopic procedures. Still, no day case surgery is allowed. Fortunately for us, this is the figures from our state, Bengal, and you can see this is yesterday's figures. Our active ratio is now 20, our recovery rate is 77, and our average growth rate has come down to 2.8%. This is data from my city itself. This is yesterday's data, and you can see for the last 2 weeks, most of the active cases have been either just about plus 10 or 20, or most of the time in the last week, it's been negative. So we are hopefully over the peak, and definitely we are doing some amount of elective work in our children. I think we have to look at the positive side of everything, and I think it's appropriate for me to end with this quotation from the Nobel Prize winning laureate in literature from Calcutta, Rabindranath Tagore. And I love this quotation where he writes that if you cry because the sun has gone out of your lives, all it will do will prevent you from seeing the stars. So we have to be positive and life has to go on. Thank you very much, Naren.
Thank you very much, Professor Chatterjee. It's amazing how, we have evolved during this pandemic and become very effective in dealing with it. In terms of while the audience gathers questions, in terms of you as the president of the Indian Pediatric Neurosurgery Society, first of all, congratulations on the webinars, fantastic webinars you have been organizing, as well as you are organizing for the ISPN. But anything else for a continent as large as US, what your society could do for the pediatric neurosurgery community?
Do you mean that? Are you talking about education or are you talking about treatment?
Both of them. What could, within the constraints of the pandemic, that the Indian society could do or would do?
Well, as you know, we're running two things. The Indian society has been running webinars regularly, like every last Friday of the month with two international speakers. From our own hospital at the Park Clinic, we're running something called Pediatric Surgery by the Masters. And this is just showing operative pediatric neurosurgery. Again, we have masters not only from this country, but from abroad. But the remit is that every day only 2 surgeries are demonstrated. So this is for trainees who are unable to actually physically see these surgeries. And this has been hugely popular. This Park Clinic Surgery by the Masters is being seen by some 600 plus people every time we have it across the world. And some of the people in your audience have also shown some of their operations. Only operations have to be shown. The surgeon has to talk about the steps of the surgery, show a surgery, and we have 2 other experts commenting on how they would do the surgery differently. And this is an educational tool because most of our trainees felt that they wanted to see surgery. And they wanted to see techniques of surgery, but they were missing out on a number of operations that they were seeing during their training period. In terms of treatment, by and large now across the country, most of us have started doing a certain amount of elective operations. Of course, emergencies never had stopped, but we are doing elective. And I think with children, the problem is a lot less than in adults. And certainly in my own experience because I do adult surgery as well as pediatric, we have really had very few children that have tested positive and have had to be shifted elsewhere or had a major problem.
Thank you very much. Questions for Professor Chatterjee from the audience and from the panel?
Sandip, Rick Boop here. I'm interested in the HDCT for diagnosis. I understand why. In our institution, I get a nasal swab once a week. And we've certainly had an incident recently where a patient was negative one day, had surgery the next day, had fever the next day, and was positive the day afterwards. How often do you do CTs on the same person? I would assume as little as possible, but if someone had a negative CT and then 2 weeks later they develop symptoms, I guess they get another CT.
So Rick, I'll tell you what we do with our adult patients first, and then I'll tell you about the children. So when an adult or a child who's over the age of 4 comes for admission, they get an HRCT before they get admitted into the isolation ward. So they get HRCT on day 1. They also have a nasal swab sent off on day 1. As I told you, in our setup, it takes 24 hours for us to get the report of the HRCT, unless it's done in our own hospital. And not all the hospitals have the facility. Mine does not. So it goes elsewhere. Report comes in 24 hours. These 24 hours, not only the child, but the mother, if there is a mother, also has an HRCT and a nasal swab. Then if it's negative, we transfer the child. And if it's an adult, we transfer the adult into the normal ward. 1 day later, they get a second nasal. So if we're doing any elective or semi-elective surgery, on day 3, they have another nasal swab whose report comes on day 4. And then we do the surgery on day 5. Morning of the surgery, if it's an adult, they get a second HRCT. So you have an HRCT on day 1, an HRCT on day 5, and a swab on day 2 and 4. And this we've had to do because we've had patients that we operated initially, negative, operated, 48 hours later, they became positive, and that is an unmitigated disaster.
Yes, Sandip, so I want to hear. I just want to say that actually, I mean, for even all the people listening, I think how you do your test and what tests you do actually depends also on really what's actually happening in the community. I think if the community spread of the virus is quite high, you probably have to do as many tests as you can, because don't forget, if a patient who comes in unexpectedly actually is subsequently found to have COVID, in theory, depending on how your hospital works, assuming even if you wear PPE, you may not be 100% protected. And then in our place, what actually happens is the whole medical team gets quarantined, right? So very soon your hospital is going to close down if you don't actually, because all your doctors will be quarantined. Because I mean, what you don't want is.
So you see, Wan Tew, this is exactly what was happening initially,
yes.
And you know, we've had a time when we've had about close to 50 nursing staff, another 30 doctors, all quarantined at the same time, and it's difficult to run hospitals like that. So now the government has made it that you have a COVID hospital and a non-COVID hospital. If you're in our hospital and you test COVID positive, we are not allowed to operate on you here. We have to inform the government, and the government will arrange for that patient to be transferred to a COVID recognized hospital. And he can only.
The question then is that while the patient was there, who were the doctors, nurses attending to the patient? Which patients were staying or living in the bed next list? Because all these patients in theory would actually have to be, again, isolated and so forth. You know, I mean, if you really follow, at least that's the rules we practice, because we don't test for patients for COVID. If they don't have temperature, if they don't have ARIs, they actually go to a normal ward.
So we are the other extreme. We have no patients who get admitted into the normal hospital. Everybody who is not tested, unless they come and get an outpatient COVID, that's for elective surgery. They can come and say the child is an LDM. The child and the mother come, have an outpatient COVID. They stay go back home. They stay in isolation. It's negative next morning. They come and get admitted into the normal ward. But otherwise, every single patient gets admitted into this transition ward, which is in a separate wing of the hospital, separate lift, separate entrance. They go and they are connected by a separate lift to the CT where they can have an HRCT. Everybody who goes to the transition ward, from the cleaners to the consultant neurosurgeons, have to wear full PPE every time they go to that ward. So there is no question of quarantine or isolation, even if a patient tests positive. Everybody is in a separate cubicle. Every doctor, nursing staff, everybody has to wear a PPE when they go to that transition ward.
Yeah, thank you. Just that, the situations are different from each hospital, and they change as well, depending on what's actually happening in the community.
Thanks. Thank you very much.
Did I answer your question?
Who, me?
No. Did I answer Rick's question? I'm just asking Rick. Is it okay? Did I answer your question? Okay.
Yeah, that was a good answer.
Great. Thank you very much, Professor Chatterjee. Certainly, we'll be looking closely how India does. I know that it had quite a bad brunt I hear with the Spanish flu, so hopefully this time it's not going to be as bad. It's now my pleasure to invite Professor Mohamed Beltagy from Cairo. He's the director of Pediatric Neurosurgery at the large cancer hospital in Cairo. Certainly, Egypt had its time with the COVID, so it will be good to hear how they have coped and what they are going to do for the next 6 months. Thank you, sir.
Thank you, Naren, and it's a pleasure seeing all of you safely. I will just make my presentation short because of time, and I think we are all following the same protocols. There is nothing new. It's all new for us. Regarding Egypt, as a pediatric neurosurgery service in Egypt, we have three providing systems, which is the university hospitals, charity hospitals, and the private hospitals. So for the university hospitals, most of the universities, or mainly down to 30% service, so 70% is shut it down, and they turn it in treating COVID cases and ICU COVID-19 patient, as well as the staff working in the university also shifted back to be helping in COVID isolation hospital. For the charity hospitals, the largest is the Children's Cancer Hospital that provide treatment for patients with brain tumors, and other charity hospitals providing other services. For the Children's Cancer Hospital, we shifted in all brain tumor cases, while benign, slowly growing, we just follow them up and postpone the admission. For most of the private hospitals, they all stopped neurosurgical service, except for very few situations, and they prepared their ICUs serving COVID. The workflow normally before the COVID was in the Children's Hospital to diagnose a brain tumor outside, then they refer it to the where there is a screening clinic that divide the cases into urgent cases or elective cases. For the elective, they prepare them for scheduled surgery. For the urgent cases, we further divide them to minor and major, which could be treated on the same day or the second day after preparing an ICU bed for the brain tumor cases. For the total number of patients enrolled till 2017 in one of the children's hospital, we have 2,134 from CNS only, and that's before the COVID. Was took by the pandemic in a trial to decrease this risk for staff patients and from the staff and the patient infection. So visits were all for all the inpatients. There were routine screening, CT chest and CBCs and serum ferritin were done for all patient and concerns regarding the results, we start doing that. And if negative, we repeated once. Then prepared negative pressure rooms in the ICU, 3 ICU beds, and 8 rooms in the inpatient room for infected patients. Again, this is the Children's Cancer Hospital, which is treating only tumors for kids and is not dealing with COVID. But once we have a COVID patient, we have to deal with, to refer it to another hospital. For the staff, we reduced the manpower with the working hours were short, PPE provided for all staff, dividing the manpower into groups with no personal interaction between different groups, so that when we get one of these groups infected, the other contacts are isolated and without affecting the other group. This was the preparation inside, again, the Children's Hospital. And preparing, again, the ICU isolation and the negative pressure bed for the affected kids. And also we had a separate isolation building nearby the hospital, which we prepared for the staff. So the staff, medical staff and the nurses working in the hospital, they infected COVID clinic outside the hospital in a nearby building where they get diagnosed and isolated in a separate building with 6 ICU beds nearby for the staff working, just for reassurance of the staff that they will have medical care whenever they, and this is of course give them some positive feeling. The steps taken by our department and the neurosurgery department with Children's Hospital, so we decreased the number of the staff available every day, limiting the surgeries only to urgent cases. Posterior fossa tumors with hydrocephalus, whenever we used to do the surgery on the same day, we just introduce the patient after CT, do the shunt, and then we prepare for the tumor. And supracellular tumors, of course, with deteriorating vision or hydrocephalus, supratentorial large tumors, and we have still to follow up our old patient with shunt obstructions and intracranial hematomas. Although we have our follow-up clinic, we still have an emergency outpatient clinic for these cases. Whenever they have problem, they contact us by phone and start scheduling a time for the emergency clinic to visit, where they got diagnosed and treated accordingly. All endoscopic endonasal procedures, we stopped doing any endonasal pituitaries or cranius, and routine CT chest before admission to all. Challenges faced the neurosurgical team that each healthcare provider with suspected COVID, we had to have a swab, and whenever proven positive in the very beginning with the COVID in March, we have to isolate for 2 weeks the infected individual, and all the contacts should be isolated for 2 weeks without having any swabs. Whenever they have symptoms, then we got swab. And this is a reduction of the number of the working personnel. The number of surgeries consequently also reduced by 65%, which we used to have 5 major surgeries and 8 minor cases per week, around 65 per month, compared to 10 major and 15 minor per week before the COVID. For the university hospitals, they reduced all to 30%, limiting the surgery only to treat the hydrocephalic cases or congenital anomalies like spinal dystrophism were postponed, resulting in more complications. Challenging facing the patient himself, that there were a long period of lockdown and there was a curfew from 7 p.m. to 6 a.m. for around 2 months, which lead to a delay in the diagnosis, leading to larger tumor sizes at the diagnosis. We have faced huge tumors in most of the cases, and of course, a prolonged and more sophisticated intensive and inpatient care. There were difficulty in reaching the tertiary care hospital from rural areas, as we are a referral hospital for these brain tumors. So there were a huge difficulty to reach when there is a curfew. Most of the patients only come to visit when they have real complication and real symptoms. And this led to decrease in the number of new cases presenting every day to our screening clinic, to an average of 1 to 2 new brain cases, compared to 8 and 10 cases before the pandemic. Although the cases were less in number, but they were much difficult and more complicated. This is one of the examples of the cases we had, which reached a huge size, although he was complaining of the headache and vomiting, but they just presented 6 weeks after complaint. This is another case who also presented to us a medulloblastoma, 4-year-old who was starting to have vomiting and minimal paraparesis, and he presented to us after having complete paraplegia of the initial presentation. As a recovery plan, during the last 2 months, the number of cases with COVID has been decreasing, so we started to reopen slowly. The hospital started also to provide the hours again. The team returned gradually to work with a full capacity, and we start opening the follow-up clinics on daily basis as before the pandemic. Exactly, this started by the beginning of August with the same full precautions. All the personnel and the patients and their relatives, they have to wear a mask. And again, any new case from the screen, even an urgent case which has to do an intervention immediately, we have to do a screening CT chest for all newly cases. When positive, do a PCR swab, and then we got this patient treated, but with full protection, PPEs, and putting him in a negative pressure room. Of course, we are expecting a second wave in the upcoming winter months, but it's too early to decide another lockdown or not. The doctor-parent and patient relationship during this pandemic, for the follow-up clinics, they had been closed for nearly 3 months, and the work was limited only to preparing the new cases from the emergency clinic and following up the urgent cases, as I discussed. But on the contrary, there were more telephone calls to encountered and to deal with the complications and to see the main complaint of the patients on telephone and asking them to bring the kid whenever we are prepared with a new bed or whenever it is a symptom that requires an intervention. There were some entertainments and art clinics that are used for the kids after the surgery and the rehabilitation. These were all closed during the pandemic, and of course, this affects the psychological status. And as therapy were all closed, there were no physiotherapy done for the patient, the kids during this pandemic. We started all this again the beginning of August, and we will return back completely full by the beginning of September. What if there is a second wave? I think we will follow the same protocol, nothing new, but the isolation for only symptomatizing cases. I mean, the doctors and the working personnel, not all the contacts would be isolated for 2 weeks, only the symptomatizing, and for all contexts. The turnover for the cases, we will have a fast turnover, which means after treating a brain tumor, we had to have him for 4 or 5 days after doing some physiotherapy and reassurance. I think this will be shortened to a couple of days after getting out from the ICU and then discharged back home, followed up on conference calls or on regular visits. Again, we have to increase the ICU beds with negative pressure for suspected infected cases and PPE for all stuff for dealing with suspected case. No patient visits will be allowed except on exceptional cases, and arranging video conferences and consultations for patients in the remote areas, rural areas, to avoid the late presentations and the tumors presenting lately, as we had some complications and patients presenting very late, which ended up in ICU bed from the beginning instead of getting him in an inpatient bed. More or less, I think that it's early, but what we are faced with is we will deal with the same way, with certain precautions after getting this more experience. And of course, we need to have a break after all that in the winter. I hope we can have this in September in the nice weather of the Red Sea. Thank you.
Thank you, Professor Beltagy. It's, I think, as you said, that we have quite well weathered so far, but even then, as you showed, the cases are coming more complex, and as the time goes, and if you don't pick up quickly back, I think then we will be starting to see more and more of our neurosurgical patients being in trouble. Any questions for Professor Beltagy, please? What about Professor Beltagy in terms of, I know that Egypt has a very vibrant neurosurgical community, and in terms of the exams and training, are they now put to the side for the moment?
Yeah, in terms of the exam, the training is run by the university hospitals still attending, but again, we reduced the manpower, so we divided them into groups. We have 2 exams, one in May and one in late October. So we combined both exams to October, so only 1 exam, and this affects, of course, the graduation of the residents and the board exam of the neurosurgery into 1, which reduced the number of trained neurosurgeons. But as a number, we have them trained instead of having 1 year, having 2 exams, we have only 1 at the end of the year. That's the only affection of the training program.
Thanks. one more question from me. In terms of the doctor, patient, parent relationship, certainly in the UK, the parents are easily contactable, and I call them up as on the telephonic clinic, and if there's even slight anxiety from the parents, then I arrange for a face-to-face clinic. So far I managed to have a good relationship with the parents. How is the doctor-patient relationship going in a busy, very busy, large practice as in yours?
We have also a phone call through the hospital telephone, where they just transfer call one of the attendees at the hospital that reassure the parents. And whenever he feels that the parents are reassured, we schedule a meeting for them where they come and have a face-to-face meeting. For conference videos, we used lately this art clinics and some kind of psychological reassurance through a video conference with one of our doctors to the patient himself, especially the kids. They got these psychological traumas, and after surgery they go out with some complications. But for the parents having some questions, it's almost a 24-hour call with the attendee every.
That's great. Thank you very much, Professor El Beltagy. Now it's my pleasure to invite Professor Miguel Arraez. Professor Miguel Arraez wears many caps as the chairman, professor and chairman of the department in Malaga, but a former president of the Spanish Neurosurgery Society, as well as the current chairman of the foundation of the WFNS. So he's connected both locally, nationally, and internationally. So first of all, it will be great to get a Spanish perspective, and then we will also, after that talk, we'll also ask Prof to give us his perspective from the WFNS foundation perspective. Thank you, Professor Arraez. I'll just put the microphone.
Okay.
Just a second.
Thank you.
Thank you.
Can you see the presentation?
Yes, sir.
Okay, thank you. Naren, first of all, thank you for having me in this wonderful webinar regarding response, recovery, and preparedness regarding COVID. I will try to give some overview of the Spanish situation, and this is the outline of my next minute presentation, some historical vignette. The issue of the COVID-19 in Spain, specifically regarding to neurosurgery. Also, I did mention something about global neurosurgery with final remarks. I will not go deeper inside global neurosurgery, as you kindly invited me to make some talk about the WFNS Foundation perspective. And looking back at past pandemics in the era of coronavirus, there is one saying: if a man is looking at the past and the future, is blind in one eye. If the man is looking only at the future, is blind in two eyes. So we have to go back to see whether we learned something about the past situation. And we have to start with the Black Death. That was something terrible in the 14th century. Just about half of the population in Europe was killed by this pandemic that amazingly again came from China and just spread all over Asia and Europe. I think that several studies pointed out that this Black Death pandemics, and also the plague of Justinian Emperor, the first one known around the year 561 or something like that, they both were due to the Yersinia pestis as the agent that made this terrible situation. And going to the specific part of Europe, to Spain, we have to mention the Spanish pandemic of 596. There was a bubonic plague coming from the Low Countries that circulated by ship around Europe, and particularly Spain was involved and was affected. There is a book, this one you can see, from Ralph McKay, Life in a Time of Pestilence, that giving some overview of the situation there. And also important to mention Spanish flu 1980. This is a little more than 100 years ago. Although was called Spanish flu, the origin of this pandemic was apparently in North America, in Fort Riley in Kansas. You can see one of the camps. But at that time, 1918, many countries were still involved in the First World War, and there was censored news, and very seldom newspapers were dealing about this pandemic. On the contrary, Spain unfortunately wasn't involved in First World War, so they had more time, and they were free to spread all the news regarding the pandemic. As consequence of that, the pandemic was called Spanish flu, but honestly, it wasn't coming from Spain. In any way, it cost something between 20 and 40 millions of deaths one century ago. And you can see one of the statistics for America and Europe, and over the period of 4 months, that was the peak of the pandemics, was something terrible for America and Europe, and causing almost something between 20 and 40 millions of deaths. The situation in Spain, the first case recorded was January 31, 2020, and these are the statistics. This is maybe 21 August 21st, that is to say 2 days ago. Diagnosis and cumulated cases, 386,000 diagnosis cases, and deaths, that's far 28,838 patients. This is something really terrible that has the country completely shocked. And if we look at the statistics, this is August 19, 3 days ago, you can see the peak around the end of March, the beginning of April, but you can see the trend in that way, the situation getting better and better and better. But now, unfortunately, we are witnessing a second peak that is worrying, all the people in Spain. And this is from one of the newspapers. Spain is leader of cases in Europe. The largest amount of cases in Europe is now in Spain. You can see the distribution. This is 3 days ago, with 2 big centers, one of them in Madrid, another one in this area that is called Aragon. Catalonia used to have also a large number. We are in Andalusia, intermediate situation. I'm living here in Malaga. And this is something worrisome for all of us. I have to mention that for many of us, and for many people in Spain, the government has been blamed for part of the failure and the situation. And they have been blamed because of some lack of transparency, maybe at the beginning, and even more for some lack of competence. We have to be honest saying that every country has been surprised or almost surprised with this terrible pandemic. And in spite of the strength of the national health system, that in Spain is not bad, the hospital couldn't, stand with such a large number of cases at the beginning of the pandemic. We think that maybe government has been falling into what is described as Dunning-Kruger effect, unskilled and unaware of it, how difficulties in recognizing one's own incompetence lead to inflated self-assessment. This is the very beginning of the situation. The government was very happy about what they were doing. I'm completely sure the situation will be under control in few weeks or in a very short period of time. It wasn't like that, as statistics have been proving day by day. And we can see the global situation. This is the number of diagnosed cases all around the world, more than 22 million. The number of deaths, almost 800,000 deaths at the moment of this picture. And in spite of the, let's say, lack of provision of the government, things not done very well, there is no good explanation why we can have such an even distribution of cases. First of all, something amazing is happening. We expected to have a terrible problem in Africa because of the lack of appropriate resources and measure of prevention. But nowadays there is there's almost no pandemic over here. On the contrary, we have several situations, several locations. Spain, unfortunately, is one of them. North America, USA is one of them. Brazil as well. So there is no good explanation why we have such a concentration of cases here. And honestly, we cannot understand very well how the situation is starting in China, where are very crowded cities like Beijing or Shanghai and many others. There is almost no cases day by day. So, I mean, in spite of blaming government or whatever of the health system, I think we are facing several things not very well understood thus far in regard to this pandemic. And I mentioned again that this uneven distribution is a very good evidence of that. So regarding COVID and neurosurgical care, well, as in many places happen, let's mention the north of Italy, neurosurgical OR were converted into ICU in many centers. In our case, in Malaga, we are the only university department for a catchment area of more than 2.5 million. We were just transferred the whole department to a private hospital that was monographically converted into a neurosurgical unit. So fortunately, we didn't have any restriction regarding the elective operation or any problem in the process of decision about emergency basis surgery. It wasn't the situation in many hospitals. It wasn't the situation in Madrid or Barcelona, where only emergency cases were done in many centers. Of course, telemedicine consultation came up, and we all have been doing many of our outpatient clinic by means of this emergent way of doing things that came to stay. And we are just in the process of some ongoing nationwide study that is conducted by our friend Jesus Lafuente, former president of the European Society, trying to analyze the real impact on neurosurgical practice. We don't have yet, unfortunately, definite figures, final figures regarding that. Hopefully soon we will have this study, including the neurosurgical pediatric practice. And talking about pediatric neurosurgery, this is not my specialty. Naren kindly invited me to participate. My profile is not pediatric neurosurgeon, but well, I did some review of the published articles, and there is one of them here, published in Child Lancet, regarding the delay access of provision of care in Italy, that were the first making some article, some paper regarding that. And what these figures are showing is that the visit to pediatric emergency globally went down to 1/5 what was expected to see according to the figures of 2018 and 2019. There is a very recent paper published in Child's Nervous System. This is a letter to the editor published just weeks ago, published online July 3, 2020. And regarding the impact in the pediatric neurosurgical emergency referrals, and I don't want to go deeper inside, but basically what is seen is that trauma just went up on the contrary of some other pathologies like hydrocephalus infection or non-spinal trauma. And basically this traumatic patient, the distribution can show that many of us are non-accident injury coming from different sources, as logically due to the lockdown, many pediatric patients were at home. And also regarding that, one of the conclusions is that in spite of the fact that head injury is coming from non-accident injuries, those head injury are harboring a more severe intracranial hemorrhage, positive from the statistical point of view. Another important factor, because healthcare is and is going to be related to the economy of the country. So one important concern for all of us is the situation of the economy, particularly in Spain, in regard to the pandemic. Pandemic is largely affecting the economic activity in Spain, and we have to mention that one of the main sources for income in Spain is tourism. This is maybe number one, number two, number three country in the world receiving tourism, and this is something good from the economical point of view. Due to the closure of the borders, the tourism is almost zero. Tourists, I mean, coming from abroad, from outside of Spain. That is something that is very adversely affecting economy. We have an historical record of public debt. On top of that, we can see this is taken from one of the newspapers, and you can see this curve that is unfortunately going up and going from, this is 2013, this is million of euros, and going up and up and up, and we are now in the highest point of this not very nice curve regarding the public debt. So talking about the impact of pandemics in economy, we are seeing what is going on in North America, what is going on in Brazil, in Spain, in many places. But what happened in the previous pandemics? Going to the Spanish flu, that is 1 century ago, what happened? Because there is, you can see this publication from Stanford, May 4, 2020. Amazingly, after this Spanish flu all over the world, and this estimation is done in regard to North America and Europe. Amazingly, small economic effects, only with the possible exception of UK. This is something amazing. And if we go back centuries ago and go to the Black Death, 15th century, the estimation are stating, the estimation, I mean the evidence is that after the Black Death that causes the death of 1 of every 2 Europeans made a positive impact on economy and social life. Basically, because there were scarce resources, so after dying half of the population, they have more things, they have more goods, and second, there was something like a let's say selection according to which only the stronger and the healthier person survive, making in some way a society with more possibilities to do many more things. So in summary, insofar as we have been going back, pandemic has finally having some positive impact on economy, although of course regarding the death and the human being, it has been something completely terrible. So I like to make some remarks in this global overview that doesn't much focus in pediatric neurosurgery for the reason I mentioned before. One of them is COVID-19 threatening globalization. We will mention something in the other talk to be given later on, but I have to mention that we all are very excited about the situation in the last decades in pointing out toward globalization. This is one of the webinars organized by UNESCO, Models of Cooperation in Neurosurgery in Low and Middle Income Countries. So regarding to that and regarding to the role of WFNS Foundation, we can see here the list of postgraduate training center that this is a network allowing young neurosurgeons from developing countries having access because WFNS and the center are waiving food and accommodation and or scholarship, but due to this blockade of the nation and impossibility to travel, this model of cooperation regarding training center has thus far been suspended. That is something terrible for the interest and global neurosurgery. Second remark regarding domestic lockdown is something pointing out toward the end of neoliberalism. We can see one of the phrases of Margaret Thatcher: societies do not exist, only individuals and families. As a matter of fact, I'm here at home instead of being with Naren and all the friends, having a cup of coffee, shaking hands, hugging each other. And, I'm here alone at home and you all in the same way. So is this some other new form of civilization? And well, see this nice picture. This is the view of Walter Molino, 1962. That is to say 58 years ago. This is his conception, Life in 2022, published in Domenica del Corriere, one of the magazines in Italy. You can see every individual in something like a crystal bubble with some sort of vehicles completely isolated. Maybe we are now in some way in that form of civilization. Of course, on the other side, this situation just forced e-learning and online activities to be empowered, and this is the modern way of doing things. I think that all these possibilities that technology is given came to stay here and has been more and more used for to take advantage of that for teaching purposes. And I think this is something good, that it's saving time and giving many opportunities to patients that are in remote areas. I like very much the presentation regarding the COVID in India, and well, in such a large country that is like a continent, these possibilities on the hands of the online activities are very good for the patient. Well, another point is regarding science and medicine intermingle with politics, public opinion, media and social media, controversies. I think that now more than ever, opinion is not coming from the government, it's not coming from the journalist, it's coming from everyone and very easily distributed all around the world. And according to that, there are many controversies. For instance, in Spain, there is some debate regarding whether or not vaccines are good or not. Not only talking about the possibility of having the vaccine for coronavirus in a short period of time, but also about the real usefulness of vaccine. And along with that, some lack of confidence on politicians. I think that the attitude and and the outlook of the politician in Spain made many of us not very happy. I think it can be the same in some other places because the president in North America, President Trump, sometimes weren't in agreement with the physicians and so on. So, I mean, there is some time of controversy, lack of confidence, and if we look back to the previous situation, let's go back to the Spanish flu, 1918, 1 century ago. Days ago in Spain, there was a demonstration of people against the use of masks. But this is not new because 1 century ago, this is San Francisco. Many of the citizens were at that time in demonstration against the use of masks. They defied the order, some of them fined or arrested. After that, San Francisco lifted the lockdown too soon. And you can see one of the boxing competition here. And due to that, another outbreak that led again the population in San Francisco to be locked down and to go back to the terrible situation they started months ago. So I think this is not new, what we are witnessing in this moment. Well, I think this is my last slide with this comment that are not only related to the specific issue of coronavirus and neurosurgery. This is also related to society, to the new way of doing things in the current civilization. And I like to thank Naren the kind invitation. This is during the course, international resident course arranged by Naren. We had the pleasure to host it in Malaga. Now, thus far, this is not possible, but I hope in the next future we will repeat this wonderful experience. I like very much having you all in Malaga, in the beautiful Malaga. And again, thank you very much for having me in this webinar and giving me the opportunity to make all these sort of comments. Thank you very much.
Thank you very much, Professor Arraez, for this fantastic talk, taking from the specific to the whole. I think it is going to have so much effects down the line that we haven't even probably started to comprehend. But in terms of the training situation for the young residents, I know that Spain has a very high throughput in terms of the training residents. How is that going on?
Thank you very much. This is a very important question, and this is a matter of concern all around the world. What happened in Spain is that, during the last period of the training program for many of the residents, there were difficulties in those centers where hospitals were obliged to do only surgery in emergency basis. So that way the possibility of learning for elective cases was, let's say, suspended. Fortunately, it wasn't the situation in my center because, as I mentioned before, and due to this possibility to move to another facility for a while, we spent 3 months in another private hospital that we fully occupied for neurosurgical procedure. We didn't have that problem, but in general, the situation has been in some way ameliorated because the government, because the training system in Spain is centralized, and fortunately the government made a decision of just expanding the training program in the terms of, instead of ending the training program for every year resident in May, as usually, it has been expanded until the end of September. That way, the new residents coming, we will have 2 residents coming to Malaga. they will join the department at the beginning of September. And of course, needless to mention that the online resources inside the department and from the outside communication and exchange has nowadays presiding our neurosurgical academic activity.
Thank you. Just one more question in terms of observation, Professor Arraez. You know, we are from a generation where we had the best of the world. You know, we had cadaveric courses. We went to conferences. We mixed with people, and for us to go to, you know, only webinar-based education, you know, we know, it is not that much of a loss. But in the new generation of the people who are missing out on the conferences, can't present their research, what's your observation? How do you see things in the next couple of years? Is this e-systems that's going to be for the next few years in your?
Well, thank you for this question. Well, I think this is something very, very important. We have tried to fill, you know, this situation of emptiness of exchange, personal exchange, physical presence in meetings, and so that has many advantages for, first of all, for the social and personal point of view. We neurosurgeons, we are, you know, very much accustomed to travel. We have a lot of friends, but we are friends, Naren, because we all met somewhere, sometime. So this is something that is not happening now. And it is not happening in the same way at the son of one of my closest friends in Almeria, the place where I was born, is getting married in 2 weeks, and I will not attend this wedding ceremony, you know. So we have to assume that for the moment, we are locked down in some way with a lot of difficulties that very not easily we will, you know, overcome. Being said that, e-learning and the other strategies and simulation for neurosurgical practice and so, well, we will try to fill this situation, emptiness, as I mentioned before, but of course, cadaveric dissection and the physical contact, I mean, the way we have to enrich our neurosurgical life, meeting people from other provinces in Spain, from other countries all around the world, that has been something to my personal experience, something enriching me quite a lot. For the moment, is not possible. I'm afraid.
Thank you. Thank you very much, Professor Arraez. That's important, the neurosurgical culture. Unfortunately, I can't see Professor Zira. He was going to join us from his holiday, and maybe there's having some problem with the internet link. So it's my pleasure and privilege to invite Mr. Richard Walsh. He's the clinical lead in the department I'm working in Birmingham Children's Hospital, with a vast experience in pediatric neurosurgery and previously adult neurosurgery. I'm here inviting him to kindly give us his perspective from the Birmingham Department of Neurosurgery, Birmingham Children's Hospital. Thank you, sir.
Oh, he finished to talk.
Hi, Naren. I'm just trying to get my
no problem, George.
Screen up. It's not coming for some reason.
Okay.
Somebody else's screen is still active.
Okay. Professor Arraez, would you be able to
yes.
Stops the screen sharing from your side, sure, please? Thanks.
Oh, sorry.
That's okay.
Sorry.
Thanks. Thank you.
Let's try again.
Thank you. Great, thanks.
Okay.
Yeah.
Narendra, thank you very much for asking me to talk this very nice webinar. I'm going to present the experience at the Birmingham Children's Hospital. over the COVID-19 pandemic. I think the experience we've had in Birmingham is fairly typical of the experience at the other paediatric neurosurgical units in the UK. Just to put it in context, the Birmingham Children's Hospital is approximately a 300-bedded standalone children's hospital. It serves the paediatric population of Greater Birmingham, which is about 3 million, and the wider West Midlands of England, which has a total population of about 5.5 million. Just to get the context, this is the COVID-19 pandemic in the UK. You can see that the incidence of infections went up exponentially in March, up to the highest figures of in excess of 6,000 new cases per day throughout April and early May, and then has progressively declined from early May until the current period of time. With the relaxation of the lockdowns in the UK, there's been a very slight resurgence of the daily infection rate, which is currently running at just over 1,000 cases a day. And yesterday there were, I think, 18 deaths in the UK from coronavirus. These are the key dates in the UK and at the Birmingham Children's Hospital. Because of the increase in the disease in March, the government recommended limiting person-to-person contacts on the 16th of March. It didn't mandate this, but a week later, on the 23rd of March, it imposed a fairly rigid lockdown. This meant that everybody had to stay within their own house. They could only go out if they were doing an essential job or if they needed to shop for food. All non-essential shops closed, all restaurants, pubs, cinemas closed, all sporting events were curtailed. So a very severe lockdown. At the same time, the Children's Hospital and pretty well every hospital in the UK suspended all elective activity. Urgent elective activity was recommenced in May. By mid-July, we were doing 75% of our theatre capacity back, and we expect to have 100% of our theatre capacity back at the end of September. So we're still not back to full activity at the moment. This is how the Children's Hospital responded to the coronavirus pandemic. As I said, all elective activity was suspended on the 23rd of March. Junior anaesthetic staff and some consultant anaesthetic staff were reassigned to adult hospitals in Birmingham. Similarly, a significant number of the nursing staff at the Birmingham Children's Hospital were reassigned to adult hospitals. As a result of this and the need to increase the spacing of beds and the number of nursing staff that had to shield because of intercurrent illnesses themselves, the Children's Hospital closed a third of ward beds. That's about 100 ward beds were closed. At the same time, we expanded our PICU from 35 beds up to 50 plus beds, because in the event of the NHS becoming overwhelmed, which never quite happened, we were expected to take all PICU cases from the surrounding hospitals that were mixed adult and paediatric hospitals, so that their PICU facilities could be repurposed for adult patients. So what happened to the COVID practice at the Children's Hospital? Well, we had between 40 and 50 acute admissions to the hospital who tested positive for COVID-19. Virtually none of these came in because of COVID-19. They came in for other reasons and were tested positive on admission. None of these children required oxygen therapy, and none of these children were admitted to our PICU because they were sick. From a neurosurgical perspective, we had 2 admissions that tested positive for COVID-19 that required a ventricular peritoneal shunt revision. And the other was a head injury, a boy who had been playing around on a factory roof, fell through the skylight and sustained a head injury, and he didn't require surgery, but did require non-ITU admission to hospital. As a late effect of the coronavirus, we had between 10 and 15 children admitted with the Kawasaki-like COVID-19 syndrome. Several of these required PICU admissions for blood pressure control or blood pressure support, but none of them died. In late May and early June, the entire staff of the Children's Hospital were antibody tested for coronavirus, and only 10% tested positive. This is a slightly, the overall positivity in the population of the UK is around 6 or 7%, so this was slightly up on the overall population. The same test was done at the University Hospitals Birmingham, the adult hospital in Birmingham. This hospital, I think, had the largest number of COVID positive ITU patients throughout the pandemic, and 25% of the staff at the adult hospital tested positive. And interestingly, the highest proportion of positivities among the staff were among the cleaners rather than the nursing or medical staff. So what effect did this have on neurosurgical activity? This is our outpatient activity by week. You can see that the dark lines represent the conventional face-to-face outpatient consultations. The light lines represent telephonic consultations. You can see that in the week that the government made its initial announcement, there was a significant drop-off in the number of children that came to our outpatient consultations. And then throughout April, the number of outpatient consultations was substantially down. And then in May and thereafter, you can see we fairly substantially increased our telephonic outpatient reviews, and the numbers of both telephonic and conventional outpatient visits returned pretty much to normal. We reserved the face-to-face outpatient consultations to new patients and to those patients having had a telephonic consultation that we felt that we needed to review in person. This shows the emergency activity in the Department of Neurosurgery. The blue bars represent the emergency referrals to our department, and the red bars represent the emergency admissions. You can see throughout the pandemic that both the emergency referrals and emergency admissions were maintained. If anything, slightly increased. There was a slight dip in emergency referrals in March and April, from 80 down to 70 a month, but the number of emergency admissions remained fairly stable. What was interesting is there was, as one of the previous talks mentioned, there was a significant increase in trauma, and particularly non-accidental trauma over this time period. This shows the operative activity, again breaking down into elective surgery and emergency surgery. The blue represents elective surgery and the red bars represent emergency surgery. Again, you can see that the emergency operative numbers were maintained or increased. April, May, June, and July were certainly, if anything, slightly higher than before. A fairly dramatic fall off in our elective activity, going down to only 3 elective procedures in April. They were a shunt revision, which was a non-urgent shunt revision, the change of a vagal nerve stimulation battery, which was down at 5% at the time, and untethering of a myelocystocele. Those were the 3 cases we did in that much. And thereafter, a very slow recovery in elective activity, but we're still far from back to our full level of elective activity at the moment. What was, I think, more interesting is the cranial tumor surgery. This shows the cranial tumor surgery done each month. It's got 2018 is in blue, 2019 is in red, and 2020 is in green. And if you look at April, May, and June, you can see that we only did one intracranial tumor in each of those months, so 3 in that 3-month time period. And in the previous 2 years, we did 16 and 15 cranial tumors in that time period. So there's been a fairly dramatic fall off in cranial tumor surgery over those 3 months. It's rebounded to some extent in April, and obviously we'll have to see how that pans out in the next few months. So what have been the overall effects of the pandemic in the Children's Hospital in Birmingham? Well, we've not undertaken about 100 elective procedures, so we're down 100 elective procedures this year compared to previous years. That primarily affects epilepsy surgery, craniofacial surgery, and dysraphic spinal surgery. We have a backlog of about 180 MRI scans that have not been performed. Most of those need a general anesthetic. And we have a number of other investigations that have not been performed. The easiest one to report is the video telemetry. We did 36 video telemetry procedures from April until now last year. We've only done 6 in this year. So there's been a dramatic fall off in our other elective investigations. And it's very difficult to see how we are going to recover that, this backlog over the next few months. Thank you.
Thank you very much, Mr. Walsh. That's a very comprehensive picture of our department. While the audience draws up questions, in terms of looking at the backlogs, how many months or years do you think that it will be before we catch up on that? But obviously that depends on what the future holds. But as things stands, if we
there's not, as you well know, Naren, there's not much spare capacity, even at the best of times in the Children's Hospital. So it's very difficult to see how you're going to catch that back up. I mean, the MRI capacity is always under a lot of pressure, even under the best of times. And the last few months, as we all know, have not been the best of times. I think it's going to be extremely difficult to recapture this activity. I think it's just it's going to hang for a substantial time in the future.
Thanks. Thank you very much. Questions for Mr. Walsh from the panel or the audience? Dr. Boop, is the experience in your children's practice in La Bonnière, is it similar to here that we are seeing in Birmingham?
Yeah, very similar. I don't know where the brain tumors go. Often they're being kept by their local hospitals and are afraid to travel across state lines. But our numbers are way down too. And you wouldn't think that would be something that you could put off till the pandemic is over.
Yeah, I mean, 75% of our tumor surgery is urgent or emergency. So it is concerning. We haven't, in the cases that we've done since June, when basically our tumor practice has come back, we haven't yet seen cases that have clearly waited far too long. But I know other pediatric units in the UK have seen children that have come in extremely late and semi-moribund that have clearly waited far too long. Hopefully we won't see that, but you never know.
And in terms of the trauma in Memphis and non-accidental injury, is that something that you are also seeing back in Memphis, Dr. Boop?
Our trauma numbers are down as well.
Oh, wow.
And, even on the adult side, we're finding that people with symptoms of heart attack and stroke will stay home rather than call an ambulance.
Wow.
And then they come in dead. I don't think our non-accidental trauma numbers have gone down any, unfortunately.
Thank you. Thank you very much, Mr. Walsh. Any other questions to Mr. Walsh? So, Mr. Walsh, thank you very much. So this is we'll take a 10 minutes break, then we will gather again at 5 p.m. UK time. Then I will outline what the projects that Listserv has done so far during the COVID period and what exciting projects we have in store for you. I think this is a time that when things are down, that's the time to find ways of imaginatively, innovatively, to try to make the best of the times, but also not only make best of the times, but also to grab new opportunities. So I hope that you will join me in 10 minutes time for the next session, which is more in terms of global outlook. Thank you very much. See you soon.
Naren, may I say something?
Yep.
Miguel Arraez did a magnificent talk. I really like it. I got also to mention that in this very, I don't know if she's live now,
Yes.
Professor Arraez. I want also to mention that in this very good historical vignette, that it was also the Peloponnesian War between the Spartans and the Athenians, and the victory of Spartans against Athenians, it was caused by a pandemic that affects the Athenian state. It's
Oh, wow.
one part of the history of the ancient Greece. Also, this.
Absolutely, absolutely. I think you're absolutely right. It has far more effect than just health.
It was also a pandemic of the history. Okay.
Absolutely.
Thank you, Naren.
Thank you very much. Thanks a lot. Thank you, Nikos. Thanks for that historical vignette. So welcome back to the second session of this symposium. We had a fantastic first session where we went from Japan all the way to the UK, and now we will go into more wider aspects of the effects of the pandemic and how we can how we have responded or how we can respond. So first of all, I'm going to give you this talk on what the Neurosurgery Listserv has been doing during the COVID. I think Neurosurgery Listserv is essentially a neurosurgical friends. It was formed back in 1998 by myself after I finished medical school. I thought that this was the time that the internet was coming, and I thought it would be a nice tool for connecting departments and undertaking research and discuss complex cases. It was a slow but steady evolution from being in numbers as well. We have now almost 1,000 members in the listserv, and we have a Facebook forum which has over 8,000 subscribers. So in some ways, we have got a good community. And the nice thing about listserv is that it's very nimble because it's just friends. But the strength of it is that it has got a fantastic faculty, probably about 350 to 400 of the leading neurosurgeons around the world, with pretty much most of the leaders of neurosurgery. So it is an ideal platform for the current situation where we can't have the traditional meetings. The thing about another thing about the listserv is that we did start webinars back in 2011. I did the first neurosurgical webinar for the WFNS back in 2011 with Dr. Mohamed. The second name escapes me, from Nigeria. He was the Young Neurosurgeons Forum chairman then. And so since then, I have been doing webinars, and last year we started the International Pediatric Neurosurgery webinar series as well. So we have had a lot of experience with webinars and electronic projects, and it was important that during this COVID period that listserv undertook them. So this is just, as I mentioned, this is an overview. So what did we do? As soon as we had actually planned the 5th International Neurosurgery Resident course, which is a traditional course which was to be held in India in end of March. This has now become a huge international event. That the first course we had in 2016 in Berlin. Then in second one was, as Professor Arraez said, in Malaga, which was fantastic. Then third one we had it in Amsterdam, and the fourth one we had it in United States in Penn State University in Hershey last year. And then this year we had a fantastic course planned in India, in Mysore, one of the most beautiful places in the world. However, a week before that course, we had to cancel it because of the COVID. And we have actually technically postponed it indefinitely, but only time will tell. So as soon as in March, end of March, on the 29th of March, I organized the impact of COVID-19 and neurosurgery, and we had all the major figures of neurosurgery, including from senior figures from ISPN, Professor Salamoa, Dr. Boop, and Dr. Radka, and from Italy, Professor Francesco Signorelli. We had a symposium on the impact of COVID that was having and how we could mitigate its effect and respond. That was in March. Then in April, we held the webinar version of the spinal component of the International Neurosurgery Resident course. This was a one-day course with over 15 speakers, with pretty much the creme of spinal surgery, with Dr. Benzel, Fessler, Dr. Rajashekar, Dr. Patkar, Dr. Sharif, Dr. Komal Prasad, Dr. Jalo. And so it was a fantastic event. And this was a webinar in a different scale, because we had a one-day webinar course with well over 100 participants, and it really proved the point that you can have a webinar that can be as much as a one-day program. And with the support of my department, then in May, again with the collaboration with Dr. Komal Prasad and colleagues in the Narayana Hospital in India, I organized the International Pediatric Neurosurgery webinar course. This was a two-day course, and we had about 40 faculty, and again, the creme of pediatric neurosurgery, who were all kind and generous. And we had over 1,000 registrants, and at any one in time, there were over 200 participants, and it was a unbelievably great success. And once again, this again showed that not only that while COVID might have hit us, but there are other ways that we can actually not only compensate, but also thrive. And that was very good opportunity. Once again, this was one of those webinars. We had a very large number of participants and faculties, and it was all free as well. And once again, the participants came across from the world, from the rich as well as the poor. Then in July, we had a neurosurgery roundtable. There was a survey done on common controversies in pediatric neurosurgery. Then we had a very open discussion on the results of the survey and how different people practice. And once again, this was a very educational experience. All those attended found it very useful. And now we have come to the current meeting. I thought at 6 months down the line, it's worth to look at how we have done. But also it's obvious that things are not suddenly going to go back to normal as we might have thought in the beginning. And I think it's important that we look at what's our plan B and what's our plan C, both in terms of patient care, so that our patients don't suffer, as well as our trainees don't suffer, and as well also for neurosurgeons. We are very much of a very close community who had been most of our brightness come from interaction with other people, other neurosurgeons, and so so I thought this would be a good opportunity for us to take stock and plan well ahead for the future. So where is the listserv going to go from here? I think, as I mentioned earlier, I think the Chinese used to have a saying that, challenge is, either you can take it as a challenge or an opportunity. And I think it's important that we, as much as this COVID is a disaster, not a question about that, but we have to try to come out with more than we lose. How that can be done is not possible because people's lives are being lost, but still we have to aim to get more than what we lose. And so in September 26th and 27th, again a weekend, the listserv will be holding the International Pediatric Neurosurgery Operative Course. In terms of the operative course, what I'm talking is that in this course, rather than talking about disease, here eminent neurosurgeons, eminent pediatric neurosurgeons will be asked to give a 25 minutes lecture on how they do particular operation, the nuances, the complications to look out for, the pitfalls, and how to get out of it. And then a panel of similar experts will give their tricks and tips. So this will be, again, but this will concentrate on operation rather than on the didactic aspect. Then in November, we would have a neurosurgery webinar conference. This would be as much as it will be as same as a conference that you usually go to a traditional place, but this will be all on the webinar, and this will be abstract submitted, abstract selected, presented, discussed. So the main aspect of this is that we still have to function in, however, life always throws things at you, but you have to not only catch those things and also try to thrive. And also for neurosurgery, neurosurgery is a culture. It's important that culture that we go back from Cushing or Victor Horsley, and we all trace back. It's not only we are operators, but there's a neurosurgical culture that is maintained through this COVID pandemic. So listserv will hold a neurosurgery webinar conference. This is not something new for the listserv. Actually, listserv started running international neurosurgery conferences back in 2005. We ran it for 9 years. We used every time as the technology improved, we used different technology, and they were very popular. And I think this will be again a very popular and timely conference. And the third project that the listserv will start, which it has laid out all the foundation, is the University of Pediatric Neurosurgery. I put university within speech mark because it's obviously not an actual university, but this would be like a master's degree level course on pediatric neurosurgery. This will be not only on pediatric neurosurgery, but on the science that underpins the pediatric neurosurgery, the ethics, the information technology. This will be a 1-year course that will be on the internet, that will be module based, and all the current information technology system allows automatic correction. And once again, we will have an international faculty, and we will also have, at the end of the course, have a Viva exam as well. So later on, when I settle down in another department as time goes on, which has also an academic affiliation, I want to transfer this into a master's course with the university affiliation. So these are the plans that we have for from the neurosurgery listserv for the pediatric neurosurgery community. Thank you for your kind attention. If you have any questions, please fire away.
Congratulations, Naren. Fantastic, fantastic job.
Thank you very much.
You start online before the pandemic situation. You are lucky, and all the people are too, because you just open doors and make the transition easy. I think it's a very, very good insight and great opportunity for us to try to open mind and see in another way how we can teach, how we can learn. It's quite new for all of us, and you start before. Now we are obliged to move on. And at the moment, we are just open the website for Pediatric Neurosurgical Committee at the World Federation. We invite all the Pediatric Neurosurgical Society for a Zoom meeting, and you sure will invite to give us ideas and how we can deal better than we are doing now.
Thank you very much, Professor Zanon. I think absolutely it will be an honor and privilege to attend any such meeting. I think, first of all, I have to thank, this is the listserv is pretty much you all, all the pediatric neurosurgeon, and in Birmingham, Mr. Walsh, Mr. Solanki, Desi, and my colleague Will have been very supportive. So this, I have been in a supportive department during this period, and this has really been, the combination of listserv and the Birmingham Children's Hospital has been a really positive experience. But listserv has always been, we are friends, we are nimble, but I always considered listserv as a pacemaker. Because for big organizations, it's difficult to, they have to have, strong governance, and they have to have financial risks, etc., etc. Whereas listserv is nimble, so we can do stuff that other people can see. And then my hope is that, the major organization, August organization, will take our projects or make it even better. But that's the purpose of the listserv. It's because we can respond easily. But by that way, the other organizations can, hopefully take on, which they have in many cases. That's the aim. Thank you. Any other questions? Thanks. Thank you very much. I will, if Professor Arraez is there.
Here.
Thank you, Dr. Arraez. Could you please give us an overview, because Dr. Jallo had an emergency. As you know, he's very supportive of all of our projects, but unfortunately, he couldn't make it today. So, Professor Arraez, would you be kind enough to give your take from the WFNS perspective from foundation? How would you see that the foundation can help neurosurgery as general, and if there are possible pediatric neurosurgery? Thank you.
Thank you very much. Well, I will. Okay. I hope you can see my presentation, Nadia?
Yes, thank you.
So first of all, I'd like, along with Professor Zanon, just to congratulate on you for this outstanding achievement. I have the pleasure to participate in several of your courses, and also to co-organize with you the wonderful international resident course in Malaga that for all of us was a really gratifying experience. You are a tireless person, and this is amazing what you have been doing for many years for global neurosurgery. And I'd like to thank you again for giving me this opportunity to talk about WFNS Foundation perspective. Well, I didn't have prepared a specific talk for that purpose, but I think that the general outline of the foundation, aim, objectives, mission, and so are very much in alignment with all the worries regarding global neurosurgery and regarding the problem of the global pandemic. I think as a brief introduction, we can see this article published in 2019, Global Neurosurgery, the current capacity and deficit in the provision of essential neurosurgical care. I have to remind that global neurosurgery, the definition could be just the aim of making the provision of essential neurosurgical care in some even distribution all around the world. But in this publication, as a summary, we can outline two things. One of them is that the estimated deficit of neurosurgeons worldwide is over 23,000 neurosurgeons. That is giving some idea about this problem. And so, regarding to that, we have to outline as well that we have many unmet needs in regard to low and middle income countries. And this slide is giving really the introduction about the real meaning of WFNS Foundation. We have seen in my previous presentation this slide regarding the global situation of the pandemic, with more than 22 million diagnosed cases, with around 800,000 deaths due to the pandemics. And this is the global map. And I mentioned before as well in my presentation that there are still several concerns about why there is some uneven distribution of cases, that giving some question mark on top of the other regarding the pandemic of coronavirus. But this map is also pointing out the areas of main interest for WFNS Foundation, that are basically some areas of Asia, some areas of Eastern Europe. Of course, number one priority due to the extension and number of people in need, Africa, and along with Africa, some areas in Latin America, and of course, Central America. So, going to WFNS Foundation mission, improvement of neurosurgical care in developing countries, with a special interest in education, training, and neurosurgical interoperative technology. I think that this is the real mission of WFNS, and I like to show this picture regarding three important persons: Dr. Martin Rodriguez and Dr. Sami. At the early 90s, just from their pocket, they put $20,000 to create WFNS Foundation, and for several years, Professor Basso has been leading this branch, the charity branch of WFNS. And since a few years ago, I'm very much honored just being the chair of the executive board of WFNS Foundation. This is just to summarize the main pillars, the strategic priorities of WFNS Foundation: educational activities, WFNS training center, there are several categories, and the provision of neurosurgical care, neurosurgical equipment, and to create, in some cases, a full operating theater for developing countries. If we talk about WFNS Foundation education activity, we have one category of courses that are led by the Education and Training Committee. Many of these courses, training courses, just done in the underprivileged areas. I like to mention Isabel Germano and Dr. Kinucci, that was the former co-chairman of the Educational Committee. There are courses from scientific committees, coordinator David Adelson, and we have at the WFNS, we have scientific committees, ad hoc committees, pediatric committees, one of the strongest one, also vascular, head injury, neuro-oncology, all the branches in neurosurgery. Recently, another one created with a special interest in developing countries, the Committee for Interoperative Neurophysiological Monitoring. I like to enhance specific actions that are very much linked to the problems of developing countries. One of them, pediatric neurosurgery. Among pediatric neurosurgery, of course, one of the main priorities is hydrocephalus. I like to mention the hydrocephalus project that in a very tireless way has been run by Dr. Di Rocco and Dr. Chubbs, and I like to take this opportunity to congratulate Professor Zanon, that nowadays is the current chairman of the Pediatric Neurosurgical Committee at WFNS, one of the strongest committees with a lot of concern and a lot of responsibilities regarding people in need, regarding unmet needs in developing countries. This is one of the courses, classical courses, just implemented in one of the meetings, WFNS international meeting in Belgrade. But my friends, this possibility, people gathering together after that, having a cup of coffee, having some fun. This is Dr. Isabel Germano. You know all my very good friend Jesus Lafuente, and they both having fun. This is no longer possible due to the current situation. So the online and e-learning activities as this one, wonderfully arranged by Dr. Naren, is what we are doing now, trying to overcome the situation. Of course, and as I mentioned before, this modality came to stay, and not only for exchange of knowledge in regard to the substitution of the classical meetings, congresses, courses, but also in regard to the neurosurgical care in consultation with a patient that cannot move due to lockdown, or they are living very far from the neurosurgical facility. In spite of the fact that hopefully we will overcome this situation, I think telemedicine as well came to stay. If we go to the second pillar, the second aspect of WFNS actions and strategic priority, we have to mention WFNS Training Center. We have basically two modalities of training center. Full program training center, Rabat, Recife, Curitiba, Nairobi, Dakar, Algiers, Zimbabwe. Young doctors from developing countries are coming to those centers to spend a full training program. They do the training program in neurosurgery, they got the diploma, and they come back to the area they are coming from just to reinforce the activity in neurosurgery or create a new unit in some underprivileged areas. I have to mention that WFNS Foundation is paying for that scholarship, and in this moment certain numbers of neurosurgeons are trained in those centers. Second category, slightly different, postgraduate training center. Let me, before moving to that, mention some continental global programs. Africa 100, Professor Sami, just inspired by Professor Sami years ago. Nowadays, another program, China, Africa, with Professor Lin Feng and Professor Qureshi, according to which certain number of neurosurgeons are going to be trained in a certain period of time. The goal is 100 in the next coming years. So going to the second category, we have to mention postgraduate training center. This is a network of centers in, let's say, more developed areas. And according to that network and to that program, young neurosurgeons in training coming from everywhere around the world can spend something between 1 month, 3 months, 6 months in those institutions, very well equipped, and that way they have the possibility to stay there. There is some contribution according to this network, and all the expenses regarding food and accommodation, and sometimes even a scholarship is given to the trainees to overcome this difficult economic situation that is as staying in a very expensive Western country could be for people that are coming from Central Africa, Sub-Saharan Africa, or Indonesia, and so and so. So this is a very popular program with a lot of satisfaction, not only for the trainees, but also for the director of the center. We are very proud to be one of this center. Let me introduce to all of you Dr. Yasser Saber from Iraq that came to our department to spend several months after a difficult situation in Iraq. After the Iraq war, his father was killed. He has to, let's say, overcome the situation and trying at the same time, he's a young person trying to get the best possible neurosurgical education. And this is Dr. Ahmad. Dr. Ahmad, now a very good friend of us. He's an anesthesiologist from Lebanon, just based and retired at Costa del Sol, Malaga area, and he is one of our donors, and he's contributing for the payment of some scholarship, and the hospital is waiving food and accommodation for young people like Professor Saber. This is something very rewarding for all of us. And you can see the web page wfns.org. You can go through the foundation, web page, and you can see the criteria just to apply as fellow for any of the possible categories. And I have to mention that this is a very popular program. But if you look at this summary, we have this weeks ago almost 800 applications, many of them already solved in the sense of approving that fellowship. But nowadays we have more than 200 applications pending. Why? Because of the issue of the coronavirus, we have to suspend this program, and now these 235 already being made the application for the fellowship are waiting, and many more that not even were able to fill the application because we have to block that because the impossibility to fly over and to go anywhere around the world. So this is a big issue that the pandemic, the COVID pandemic, is provoking and adversely affecting one of the most popular and most interesting project of WFNS Foundation. For those interested at the webpage, you can see the guideline for to become postgraduate training center. We have basic requirements. You have to be credited in your country to train neurosurgeons, and also you have to waive food and accommodation and or a scholarship for the young colleagues. With those basic requirements that include generosity, you can be part of this wonderful network that very much is helping people from developing countries. What is the way we try to implement everything? Let me introduce to you Dr. Ben Okanga. Dr. Ben Okanga is from Kenya. He was trained in Nairobi under Dr. Mahmoud Qureshi direction. WFNS was paying for the scholarship during the full period of training. And after that, Dr. Ben Okanga moved to Mombasa. Mombasa is at the coast of Kenya, and at the Coastal General Hospital of Mombasa, we just provide instrument, a microscope, bipolar, drill, cranial set, spinal set. That way, neurosurgery did start 1.5 years ago at the Mombasa area. This is the way we try to implement training and at the same time to implement neurosurgical equipment. I like to thank Esculap, Storth, SACE, and the other donor that at a very cheap price providing us all this equipment that are going to be donated to the area where the neurosurgical facility is created. This is the way we try to put everything together. So regarding the model of cooperation of WFNS Foundation, I like to unfortunately say that the COVID has obliged us to cancel this program. Regarding educational activities, are not stopped, but we have the limitation we have mentioned before. And regarding neurosurgical equipment and care, we continue working in the issue of donation, but the physical act of donation of the instrument, microscope, and so to developing countries is nowadays under huge difficulty due to the blockade of the borders among countries. So this is the way first WFNS Foundation try to contribute to improve neurosurgical care all around the world with a special mention to developing countries. And second, this is the situation. The COVID is adversely influencing against the aims and goals of WFNS Foundation. And just to finish my presentation, I'm living in Malaga, Spain, Costa del Sol. You all are very welcome. Some of you already came to stay with us, and you are invited once and again. And let me tell you that one of the reasons Malaga is well known, not only because of the seaside and splendid weather, is because Pablo Picasso, the famous artist, was born there. Pablo Picasso is very well known due to Cubism way of painting that made him really famous, but not many people know that Pablo Picasso, his early ages were devoted to the art of painting that is called hyperrealism. And this is painting, science and compassion was done when he was 17, 18. And you can see the doctor. The doctor is just looking after the sick mother. The nun is just holding the baby, and the baby is looking at the mother. Science and compassion, let's say charity and education could be, let's say, the motto for WFNS Foundation to help people in developing countries, people in need. Thank you very much for your kind attention. And Naren, thank you again for having me participating in this wonderful seminar with these wonderful colleagues. Thank you.
Thank you, Professor Arraez. This is once again fantastic presentation from you, detailing the important work the foundation of the WFNS does, and how many of those in this forum might also help with the work. It's quite inspiring how much actually goes on that we may or not fully appreciate how much hard work you and your colleagues put. Questions for Professor Arraez from the floor?
Congratulations, Dr. Miguel. Fantastic information. We know that World Federation have two kinds of training centers. You can train in high-income countries and be back in the low-income countries, and you can stay in the low-income countries and try to provide care afterwards. I talk with some of neurosurgeons, young neurosurgeons that were training in high-income countries, and when they are back, they can face difficulties that they are not prepared for the local situation. I would like to ask you, for the future, did you believe that is best focus for the World Federation Foundation, focus on the local training for the people stay where they are training, or train in high-income countries with high-tech and send back afterwards?
Thank you very much, Dr. Zanon. This is a very good question that is very much related to one of the worries of one of the concern of WFNS. Let's say that we have some scale, or let's say some levels or priorities. Our basic priority is trying to have basic neurosurgical care in underprivileged areas. We are talking that sometimes, for instance, Mombasa area is 5 million inhabitants without any neurosurgical care. So what we want is not putting there a unit with a sophisticated microscope or, you know, or proton beam therapy. What we want is just trying to avoid people dying because they are falling from a coconut tree or wherever. So the priority is trying to establish neurosurgery, of course, initially basic neurosurgery. So we need trained neurosurgeon and we need equipment. We provide for free, of course, the equipment that we are buying at a very low price to the companies. And regarding the issue of the training, where to train people? Well, when there are facilities good enough nearby, logically and naturally, they can go there. For instance, there is one of the first training center was in Rabat, and the Rabat center that is fully equipped can, let's say, provide excellent neurosurgical care for people coming from Africa, North of Africa, Sub-Saharan Africa, and so. Sometimes the center, the Curitiba Center, for instance, is run by one of our colleagues and in Brazil, and this is a first level center. So if this center and this country is allowing people coming from developed countries to be trained for 5 years, they go to this, let's say, high income country to spend the period, and then they come back to their original country to contribute to development of neurosurgical there, and in some cases to create the unit. This is something that is not the ideal goal. Why? Because after 5 years, we all know that we have some limited capability just to do neurosurgery. But this is the best we can do. And this is some, let's say, initial way of establishing neurosurgery in certain areas that very hardly have, you know, the basic surgical care in general or obstetrics care. And we have example of, because this program started 15 years ago, and now we have examples of center who started with one person, and later on a second one joined the first one, and so and so, and now they are 8-10 people department with good capability to train some other young fellows that are coming from nearby areas. And this is what is happening. At the same time, for the situation according to which Dr. Ben Okanga that went alone to establish neurosurgery there, we have now preparing a program, something like a subcommittee, just joined by those neurosurgeons that are almost alone over there, because they can get together. They will have the support of WFNS. They will have, they will need some information and some training, not only about the way of doing a craniotomy, but neurosurgery is very complex, but about the way of trying to conquer some anesthesiologists to develop some sort of neuroanesthesiology, neuropathology, neuroradiology, and so on. So establishing a unit is not only putting a microscope and a neurosurgery. So it's something more complex. And in our aim to establish neurosurgical unit as strong as possible, we are now just about to launch some program that is going to, this is something new, that this is, this program is going to be called WFNS Foundation Partnership Program. That is to say that in few weeks, we will send an invitation letter to all the societies around the world. We have been creating the neurosurgical global map that has been trying to identify. Dr. Key Park has been in charge of that. And we have been trying to identify all the areas and all the countries around the world that are in need. Some of them nobody knows about that, because in Zimbabwe, if there are need, because several neurosurgeons are claiming for instrument or training or whatever, we are aware of that. But in some areas, there is no neurosurgeon, there is no any neurosurgical claim, let's say. We have been trying to identify those areas without anything. And when this list is already done, and we will ask the societies from Western countries or countries, high-income countries, to make the choice of their partner country or partner area in need. That way, we will try to promote the exchange of neurosurgeons, I mean, young neurosurgeons from developing countries going to Spain. If we have been linked with Tanzania, people from Tanzania are coming to Spain. People from Spain is going to Tanzania, and actually it has been like that with Jose Piquer, working with Moody Qureshi in the hydrocephalus problems there. And also we will try to establish all the sort of needs and goals you can imagine, trying to improve the situation in the partner program, in the partner country. This is the way we have been trying to help. This is something ambitious. There are a lot of difficulties because you need people encouraged to do that. It costs money. We need a very strong fundraising program, of course, and we need basically generosity, like in the picture of Pablo Picasso. And I'd like to take this opportunity, Dr. Zanon, to again congratulate on you for leading one of the most important committees in WFNS. And I'm saying that because I've been coordinating the activities of all the committees for years in WFNS. I know the importance of those committees and the importance of Pediatric Neurosurgical Committee.
Thank you very much for your words. Thank you.
Thank you. Thank you very much, Professor Arraez. Before we go to the next talk, just to mention here, I will write to Professor Salamova, Dr. Boop, Professor Zanon, and to Professor Arraez as well. One of our the Listserv's project is to have a on-call, international on-call for pediatric neurosurgery. I'm very fortunate in my department. I've got very senior colleagues, Mr. Walsh, vast experience and expertise. Mr. Solanki, again, very experienced and great expertise. Mr. Rodriguez. And so, to be honest, it has been a really nice time in the department. I have had people with amazing experience, making sure that, I don't fall into the usual pitfalls or with the tips. And so the aim of the International Pediatric Neurosurgery On-Call is to have a cadre of 30 odd neurosurgeons, senior neurosurgeons, who are either coming to retirement or just recently retired, to have through the WhatsApp take calls from neurosurgeons from developing countries who have limited pediatric experience to advise on on-call cases. But it would be great if we could all collaborate on this and make this a project that's for, during this COVID period, is something that's really useful. So thank you again. I'll write to you all, but it really gives me a great pleasure and privilege and honor to introduce Dr. Boop once again for pediatric and international neurosurgeons. Dr. Boop doesn't need any introduction, but Dr. Boop is a neurosurgeon at the Labonia Hospital and as well as the famed St. Jude Hospital and also St. Murphy Clinic. He is past president of the WFNS and the former chairman of the American Board of Pediatric Neurosurgery. He's the president-elect of the ISPN and very much not only a leading pediatric neurosurgeon and a great educator. So education is other side of patient care. So it would be great to hear from Dr. Boop what his thoughts are. Thank you.
Thank you, Naren. You can hear me fine?
Yes, thanks.
Yes, and I would just like to say congratulations to you. It doesn't go unnoticed the amount of effort it takes in coordinating a day like this, and you've done it time and time again very successfully, so thank you for that. I wanted to start out borrowing from Miguel and looking at lessons from the past. The Spanish flu, if you think of it, in 1918 to 1920, as Miguel said, 500 million people, or in those days, a third of the population of the world was affected by it and resulted in some 20 to 40 million deaths. And it's interesting that this H1N1 flu virus had a predilection for young people, whereas our current pandemic mainly has a predilection for old people. But in my country, keep in mind that the Flexner report was published in 1910. So prior to that time, medical education was pretty much done by apprenticeship, and there were quote medical schools unquote all over the place. In Memphis, where I live, there were 5 medical schools prior to the Flexner report. But once Ibrahim Flexner put forward the notion that a medical school curriculum should include basic anatomy, physiology, basic science, then those coalesced into one university medical school in our city, and so forth across our country and then around the world. And of course, the world has changed tremendously since that time. When we look at the rapid advances in communication just over the past decade, it's hard to believe that just in 2007, there was no such thing as a cell phone app, and now we live by our apps and our connectivity. And in this pandemic, it certainly created the opportunity to share knowledge around the world as this pandemic affects various regions. And it certainly affected education in a way that I think is irreversible. And I'll go through some of my thoughts on that. But certainly we've learned some valuable lessons in terms of how to have days like today that are much more affordable than our traditional fly-in meetings, where we book plane tickets, we book hotels, we fly across the world on a meal per diem, and hope that our universities will reimburse us for this. So nowadays we have put a hold on traveling for teaching courses. Our national and international conventions have been put on hold. No travel for residency away rotations, and this now puts us in a position of interviewing residency applicants by Zoom or by internet without actually having the chance to meet with them and work with them. Similar with oral board examinations, our FEBNS has canceled our spring and our fall oral exam fly-in meetings, and we're going to try to examine over 200 applicants at the end of September by 3 days of Zoom, and we'll see how that goes. And I'd like to point out that this has also affected our ability to get away from work and to relax and to get our wits back about us at the end of a stressful period of work and sick patients. And I'll throw in this video from Malaga at the last meeting that Miguel hosted there, just to show you what a consummate host he is. Not only can he pick good music, he can dance as well. So in terms of the world economy, the physicians are in a position where, unless you're employed by a government or a hospital, you're not sure what your income is going to be this next year. At the same time, with medical students not coming to campuses, but staying home and having virtual lessons, the medical schools are struggling to know what their expenditures are going to be this year, and asking for help from their governments to stay in existence. And then our graduates have often been promised job opportunities only to find that their employment has been put on hold because the hospitals who've offered them employment have had to put a freeze on their purchases and on their programs. And so capital expenditures for new equipment have often been put on hold for another year. In terms of our globalization, medical tourism has been seriously reduced by the pandemic. Oftentimes, patients can't get visas to travel for medical reasons from one country to another. And out of fear of the pandemic, many people are afraid to cross state borders to go to centers of excellence for their care. So this has severely affected some referral centers, such as our own. Our numbers of brain tumors are down significantly compared to past years. And then opportunities for international medical graduates to travel to other countries to train has been severely affected by the hold that's been put on travel visas by various countries, including my own. So it takes a global effort to deal with a pandemic like this, and the sharing of resources like we've done today, talking about lessons learned in other countries, is translating into rapid changes in healthcare at major training centers across the world. But we've also seen the effects on socialization, our ability to get away and enjoy a ball game, enjoy a symphony, enjoy time away from home, just relaxing. And I think this has created an untold stress on not only the physicians, but also their support people. We had one of our spinal instrumentation reps commit suicide 2 weeks ago. He's been a part of our program for 20 years, and no one would have guessed that he had any sorts of problem that would have led to this, but it opened our eyes to the stress that all of us are under in the midst of this pandemic. In terms of COVID and neurosurgery, we've tried to adapt to doing microneurosurgery dressed in full PPE, wearing N95 masks and face shields. We've tried to adapt to transsphenoidal surgery and looking at ways not to spread it to the whole OR crew. And our traditional learning modalities where residents meet in a classroom and we give them lectures from week to week has completely changed. Likewise, being on call as a neurosurgery resident, or even being conscripted to work in an intensive care unit and to learn to become a pulmonologist in an ICU has been different for our trainees. So just some thoughts on COVID and neurosurgery. In many training programs, elective surgeries have been put on hold. The exposure to basic neurosurgical surgical techniques has been reduced for our residents. PPE shortages and COVID testing of patients has caused a high number of cancellations in elective and urgent surgeries, and it shed a whole new light on performing emergency surgeries in patients who are untested. Even patients with significant neurosurgical problems are hesitating to come to the hospital. I mentioned that our brain tumor numbers are down, but likewise, patients with heart attacks and strokes are staying at home and showing up a day or two later with a completed stroke and not much intervention to be performed at that point. Our neurosurgery residents are being pulled to help staff COVID ICUs. And one of the good things we've learned about that is that neurosurgery residents in general are very good intensivists, and it doesn't take much for them to adapt and to perform quite well compared to their medical colleagues in the intensive care setting. Our residents have had to alter call schedules to deal with exposures and quarantines. I know our residents typically cover several hospitals at night, and when the pandemic came, we were asked to change to call schedules that isolated the residents from one another, team A and team B that could not socialize in between, so that if one person came down with a COVID infection, They did not infect all of their colleagues and jeopardize our ability to cover the emergency rooms of several hospitals in our city. And our weekly educational conferences are now either virtual or canceled. And we've learned quite a bit from that as well. So the good, the bad, and the ugly, these virtual conferences have given us a marked increase in the virtual symposia available around the world, such as this one, those held by the WFNS, the Brazilian Society, Indian Society, etc. These virtual lectures are of high quality. They can be recorded, they can be played back. We can send out links to these virtual meetings such that anywhere in the world can log on and play them when it's not in the middle of the night at their home. And we've seen increased resident and faculty attendance in our teaching conferences doing it by Zoom. So whereas in the past, if we had an M&M conference, people had to leave 6 different hospitals and drive to a central location, they can now participate in the M&M conferences from a computer or from their cell phone in the surgery lounge, in the call room, from the emergency room, or from wherever they may be. And many times this is from their home as we socially distance. It's easier to arrange virtual visiting professors from around the world. It's quite affordable. We don't have to arrange airfare, hotels, and we can easily change the dates if someone gets sick. On the downside, there may be less interaction between faculty and residents. And as such, it's harder for those of us running training programs to keep our finger on the pulse of what the residents are thinking or what sorts of problems they may be having. It's harder for teaching faculty to appreciate how much learning takes place over Zoom. Many times we see our residents are present with the video screen turned off and just their name or picture on board, and find that the residents may be working on consultations or progress notes while lectures are taking place. And it's not until you ask them a question that you find out that they're inattentive. We may have faculty sign in and not say a word, only to find out that they signed in and went off to do other things. And although we thought they were participating, they were not there. And then the ugly, and this was alluded to earlier, the culture and the personality that is developed within a training program comes out of our educational interaction. Our residents learn how to act like neurosurgeons from watching faculty to faculty interactions at our teaching conferences, as well as on the ward and in the operating room. The residents get together, and when they're in the same room, there's a degree of camaraderie. They share stories, they tell tales, they get to know each other and have fun together. And then the faculty resident interactions that occur in our teaching conferences all come together to create the personality of a neurosurgeon and the personality of a program. And without actually being together and meeting and being able to enjoy these times together, I fear that the development of a training program's culture is going to be harmed. So in terms of medical students and medical education, I'm just going to run through this reference from the Journal of the American Medical Association that came out a couple of months ago, looking at implications of COVID-19 for this next residency application cycle. And they point out that in the United States, 40,000 medical students and physicians are applying for residency programs this year. Last year, the average medical student applied to 65 different programs per applicant. And now that the application program process is online, it's very easy for them to click a link. And other than having to come up with different personal statements for different programs, the application process has become quite simple, and the number of applicants per program per cycle has gone up. And if we look at international medical graduates, the average was 137 applications for a year. This has created substantial costs for the applicants, but it's also created potentially unmanageable loads for program directors who have to review all of those program applications and decide whom they may interview and whom they may want to bring to their program. COVID-19 has caused closing of testing centers, and as such, applicants have been unable to take portions of the USMLE. This is particularly critical to the international medical graduates who can't take the required Step 2 clinical skills examination in order to qualify for the match for some of our clinical programs. Medical schools have been forced to shorten their clerkships. Many have shifted to virtual rotations where residents or medical students cannot travel to that medical school and visit, but may be able to log on to the teaching conferences and participate virtually in the teaching conferences at the individual centers. And then most recently, our medical schools have canceled all away electives. So there's a reduced opportunity for students to get letters of recommendation from the various department heads with whom they've trained. They have reduced their ability to evaluate the different training programs. And it's limited the teaching faculty's ability to adequately get to know the applicants. So now I'm faced with a situation where we will do online interviews and I have to decide whether I want to commit to someone a 7-year training in neurosurgery without ever having actually shaken that person's hand or met them personally. And it's a bit unnerving. Some temporary solutions, conducting virtual interviews, allowing students access to view and participate in our virtual teaching conferences. They may have to waive requirements as letters are late or not available, letters of reference for the applicants. Likewise, USMLE scores may come in late or not be available at all. And we may have to limit those accepted into residency to those who have trained within our own programs simply because we know them and can adequately access them. Alternately, in the past, the number of applicants, interviews an applicant could attend was limited by time and travel expenses. Now there's no limit on the number that they can apply to. And these constraints will become less relevant with virtual interviews. But one of the fears is that by increasing the number of interviews per applicant and the number of people applying to a single program, it may potentially increase the number of unmatched applicants and the number of unfilled program slots at the end of the match. We'll just have to wait and see. But there are opportunities to improve the interview process, and we're learning these as we go through this process. We may have to adjust the timeline for resident applications. We may have to modify the application process to make do with fewer letters of recommendation or assess residents without certain test scores, such as their USMLE exam scores. And this may encourage a more holistic review of the individuals, looking at their personal attributes, aptitudes, and experiences in context of their future and its relation to the mission of an individual training program. The programs may limit the number of applicants they review. They may expand online program information available to the applicants, such that they could do a virtual tour of the program, for example. This may cause programs to have to prioritize the quality of the information that they require. And it may create a temporary exception to this all-in policy where if you participate in a central match process, you have to only take patients, take residents through the match. It may be that we would be allowed to take some people outside of the match if we know ahead of time, for example, that they trained in our program and we want to keep them, and then only have fewer applicant positions available from within the match. And we may cap the number of interviews per applicant and allow applicants to designate preferred programs just to reduce the amount of work it takes to review that number of applications. So in conclusion, medical education, residency training, the way we practice is going to change, has changed, and will continue to evolve as we learn to deal with this situation. And some of the things we've learned will stay with us forever. Some, such as the development of the culture of our institutes, needs to change. We need to get back to where we can meet face to face, at least for parts of our training, such that we can be a part of creating the culture of our institutions. Thank you.
Thank you very much, Dr. Boop. That's a comprehensive view on training from you, and this is very useful for all of us in other countries. Questions to Dr. Boop from the floor? Dr. Boop, if I may just ask, if you have covered it, I apologize. How is the pediatric fellowship interviews or selections? How are they? How has that been affected?
Well, the pediatric fellowships in our country, in the United States, we now have over 30 pediatric neurosurgery fellowships, and we have 15 to 20 applicants per year. So we have well more fellowship sites than we have applicants at the present time. And we have a central match for that process. So I think the interviews, the actual fly in and meet has been put on hold, and it's all done virtually right now.
Thanks. And once again, if you are covered, I apologize. What's happening to the exams, the neurosurgery exams that
well, the written exams
yeah.
are now being given online, and that's going well. The oral boards, as I mentioned, are now going to take place by Zoom, and as you can imagine, 2 examinees per candidate, 3 sessions per candidate, trying to coordinate that for 200 people over a period of 3 days. It's we'll see if it can work, but it's certainly going to stress the system.
Thanks. Thank you. Any comments from Dr. Harbaugh from your program, sir?
Yeah, so great talk, Rick. And, you know, I think everybody in the United States is facing the same kind of challenges. I'm pretty sure we're going to see a real uptick this year in the number of students who trained at a given institution who then get accepted into that neurosurgery residency program. I mean, that's something that we're certainly considering. We take 3 residents a year. Right now, we have 2 people at Penn State that we would love to have stay at Penn State. And I think that's, you know, likely to happen, because whereas in the past, everybody would have been competitive, now you have a group of people that you know very well because you've worked with them, and you have another group of people you will never meet. And so I think it does change the way we choose residents. And it's not just not having, you know, students come in to interview. You know, one of the things that happens in many United States programs is we would get, you know, 20 to 30 outside students who would rotate on our service for a month, and then you'd get to know that group, and so you'd have a fairly large group of candidates who were competitive and that you'd gotten to work with them. That's going to change this year. So my bet is we're going to see a much different distribution of where people go for their residency.
And the deans are encouraging that. So
thanks. Thank you. Doctor, here we have got Dr. Ramirez. She's the president of the Mexican Society of Pediatric Neurosurgery. Sorry for ambushing you, Dr. Ramirez, but in terms of training in Mexico, how are things going there? I'll just, I think there's a bit of an echo there. I'll just, yes.
Hear me?
Yeah.
Okay.
I think, Dr. Ramirez, I think there might be 2 instances of you. We can come back to you in a second. Let me just, I think there are two, there's an echo coming through, Dr. Arraez.
Yes, if you call in by phone and use your computer, that happens. So that I don't know if that's the case here, but it's one of the things.
We will come back to you, Dr. Arraez, if that's okay.
Can you hear me?
Yes, that's fine. Yes, absolutely.
Okay. For training in pediatric neurosurgery in Mexico, we only have 3 hospitals in Mexico City with this specialty, and we have only 7 residents now. And now in August, we take the surgeries with program, and we have several subscription for residents and the fellowship in the National Institute of Pediatry and the Hospital Infantil in Mexico and the Pediatric Hospital in National Medical Center, and in the rest of country we don't have training in this specialty.
And currently you are also having curtailed your practice, I take it, in Mexico as well. How bad is the coronavirus in Mexico?
For the last 5 months, only performance emergency surgery for hydrocephalus, congenital malformation like spina bifida, and brain tumors, and in some case for traumatic brain injury in pediatric patients. And for the last, in August, we performed the programmed surgery for craniofacial surgery principally, and the spinal surgery.
Thanks. Thank you very much. Dr. Arraez is very active, apart from being the president of the Mexican Society, very active in use of internet for education. So I hope we can work together in future. So now, thank you very much, Dr. Boop. Again, I will now introduce Dr. George Ibrahim. I'll let me just Dr. Ibrahim.
Hi there, can everyone hear me?
Yeah. So Dr. George Ibrahim is a consultant pediatric neurosurgeon at the famed Toronto Children's Hospital, coming from a great pedigree, and it has, as you know, a huge research portfolio, and Dr. Ibrahim has also got a great research portfolio. So we will see how the COVID is affecting and how they are trying to mitigate it in terms of their research practice. Thank you, Dr. Ibrahim.
So thank you very much for having me. Good afternoon, or good evening, or good morning, depending on where everyone is. I'm George Ibrahim. I'm the newest actually neurosurgeon at Sick Kids in Toronto. And the story that I'll be telling today is really a story in progress, because we certainly don't have any of the answers. But I could tell you what our experience is and what our outlook is about the future of research in our field. This is where I work. It's the Hospital for Sick Children. It's in Canada, Toronto, Canada. It's the largest referral center in our country, and I am one of 6 pediatric neurosurgeons here. So to tell you a bit about our research interests, at our division, Peter Dirks has an interest in cell biology, particularly pertaining to brain tumors. Jim Drake has an interest in surgical robotics, among many other research initiatives that he's undertaken over his career. Abhay Kulkarni is primarily interested in clinical trials involving hydrocephalus. Jim Rutka, again, one of the giants in our field that I'm fortunate to work with, primarily has an interest in molecular biology of brain tumors. Michael Taylor is interested in genomics, predominantly medulloblastoma and ependymoma. And my research practice, which is the least mature of the 6 of us, is predominantly in connectomics, neuroengineering, and in epilepsy. What I hope you'll appreciate from these different domains and interests is that the research that we do really spans the spectrum of bench to bedside. Within our division, there are individuals that are interested in microcellular processes to clinical epidemiology and clinical trials. And really, our research program has been affected quite substantially by the COVID pandemic, I think in 2 ways. The first hit to our research program has been the direct consequences of COVID-19, which all of us, of course, have been through. This includes suspension of all research activities at Sick Kids, and we are currently in the middle of a phased reopening of our research program. I won't go into this to a large extent because many hospitals have a similar approach with phased reopenings. This is just a picture from our 60-page reopening plan, which I will not be going into in this talk, but it's essentially in 4 phases. There was phase 1A, where access was very limited, phase 1B, where it was slightly more liberal, onto phase 2, 3, and 4. Phase 2 was when we were allowed to bring in research participants, and that started just a few weeks ago, and we're currently in phase 3, where we're allowed 60% occupancy of our research capacity. And this should look familiar to many of you. This is one of the illustrations that our teams have devised at Sick Kids, indicating how we are best to social distance within a research environment, whether it be a wet lab or a dry lab. There's very strict guidelines that are very much enforced on how we are to occupy our research capacity. The other direct consequences of COVID-19 is, of course, personnel issues. Many students have had their experiments stopped. Many of them have had to start from scratch now that we've proceeded to reopen. A particularly vulnerable group is our international population, and many of our students and trainees are from elsewhere, and that's created many layers of complexity for their research and their productivity, and also morale. With research in a lab environment, as Dr. Boop referred to, one of the highlights of this type of endeavor is having a team and working together as a team to solve a problem. And you lose something when you try and do everything over Zoom, especially when your research is halted. You know, I think if you are a resident and you're still working in the hospital, you still have a sense of collegiality and you still have a sense of teamwork. It's not the same as pre-COVID, but I think in research there's a certain vulnerability to being isolated, and certainly I've seen that affect the morale of personnel in my research lab and at Sick Kids. And of course, study conduct. There's missed visits and data, there's interruptions of study treatments, there's protocol deviations, and impact on key outcomes. And there has to be a reorganization sometimes of entire research experiments to accommodate the disruption that's occurred as a result of COVID-19. But equally important is the second hit of COVID-19, which are the indirect consequences as they pertain to research. And one of those consequences that certainly we're feeling right now is funding. The Canadian government has laid a framework to prioritize COVID and infectious disease research. And although our research in the neurosurgery division is fairly diverse and fairly broad, none of us have a infectious disease focused research program. And that does put us in a more vulnerable position as we compete for funding through national initiatives that are fairly limited. And alluded to in many talks before, and certainly there's no need to overemphasize this, but the idea of cultural changes that are associated with COVID-19. So this has to do with patient anxiety, participant recruitment, bringing people into the hospital to take part in research programs is very different than bringing a patient in for a surgery that is needed. Obviously, this has many, many implications, not the least of which is an ethical implication. You know, how do you consent a patient to participate in a research study without undue influence, without coercion to participate in that research study when they feel a baseline level of anxiety because they don't want to go into the hospital because of fear of COVID? And certainly that's something that we have addressed and something that I think we are moving towards good solutions to, as I'll talk about. We know this, as has been mentioned many times before, that crises drive innovation, and the Spanish flu has been alluded to many times already this morning. And we know that it has driven many of the innovations that we celebrate today. The Spanish flu was in part responsible for boosting socialized healthcare, which in Canada is certainly the case. It has emphasized or enhanced organized collection of data. It's brought a spotlight on international responses to emergencies, had some effects on hygiene and sanitation, and there was a post-flu optimism that followed the Spanish influenza that led to a change in the way that people performed medicine at the time. And in a very similar way, we have attempted to introduce innovations that advance our overall conduct of clinical research in a way that will allow us to do that following the COVID pandemic. And I looked at some of the literature around this outside of the neurosurgical community, and there have been some reports published on the impact of COVID-19 on clinical research in other fields. Catherine Tuttle is a nephrologist who wrote a very nice commentary on this, and I found that much of our experience is actually quite similar, looking at the challenges and the opportunities that COVID had put us in. I wanted to summarize some of the initiatives that we have instigated in our research program as they pertain to COVID research and non-COVID research and its effect on our neurosurgical research. These are changes that have really been implemented over the last few months, and I can't really say that I know the long-term consequences of any of these, but I do have some cause for optimism that these changes will lead to positive sequelae in future neurosurgical research. The first, of course, is research priorities. I mentioned that both within our institution as well as outside of our institution, particularly as it relates to funding, COVID research has been prioritized. And as a result, for non-COVID research, resources have been redirected. I think the net overall outcome of that is negative in the short term, but presumably if the COVID pandemic is mitigated because these resources are mobilized in a way to effectively manage it, that would have a long-term positive effect on our ability to perform clinical research, 5 years down the road. So I do have cause for optimism in that regard. The other area of policy shift at SickKids has been our IRB policies. And I have to say, I've worked at many institutions, and the SickKids IRB is quite rigid for a good reason. But they have historically been very, very meticulous about detail in all our research protocols. Due to the COVID pandemic, there's now been an expedited review of all COVID-related research, but also a reevaluation of how non-COVID research is scrutinized by IRB at the IRB board at SickKids. And that's allowed us to now perform remote recruitment of patients, whereas before that was frowned upon, barring exceptional circumstances. We're now able to contact patients for recruitment remotely. We're able to get consents remotely, and potentially there are mechanisms in place for the IRB to review the protocols that we submit to them through their boards remotely as well, meaning they don't have to convene in person once a month or once every 6 weeks to review the protocols that come to them. They could potentially do that in a more expeditious manner. And I think that has a significant positive effect on the ability to perform neurosurgical research at our institution, and certainly rolls over to many others. In terms of finances, I mentioned that much of the resources have been directed towards COVID-related research, and that has been in the form of accelerated contracts and increased budgets aimed towards virology-focused work. But that's also allowed us to potentially develop novel collaborations with some of our colleagues at SickKids who specialize in virology or organoids, who may find links to neurosurgical research that were previously not identified. When it comes to non-COVID related research, a lot of finances are being diverted to focus on participant outreach and the technology to facilitate participant outreach, knowing that a lot of patients do have anxiety about coming to the hospital, and the system of patient recruitment and trial design needs to change to accommodate the new realities of COVID. And I do think that this is overall a positive net outcome for neurosurgical research, which will allow us to include many participants in trials that would potentially be inaccessible to them if the traditional way of recruiting them were to be followed. In terms of study timelines, COVID-related research has been accelerated. I have to say that many timelines for our non-COVID-related research have been extended. I hope that that's a neutral net effect, but there is the potential for a negative consequence there. One of the great things about our changes over the last few months is their impact on investigators and teams. We've heard from Dr. Boop about how there's certainly the ugly side and there is the bad side to online and Zoom meetings, and certainly that's been our experience as well. But there has been a greater focus on multidisciplinary work as a result of the COVID pandemic. And in non-COVID related research, there's been a greater emphasis on cross-training, flexibility, and nimbleness. And I can't imagine that being nimble and being flexible and having the ability to assume many roles within a research program will lead to anything other than positive long-term consequences in the neurosurgical domain in the long term. And of course, patient access to studies. I alluded to this previously. We have very few COVID cases, but essentially every patient involved that's been diagnosed with COVID has an opportunity to participate in a COVID-related research study. And also healthcare workers are increasingly encouraged to participate in COVID-related research studies at the hospital. I mentioned that a lot of our emphasis has shifted towards enhancing engagement for non-COVID related research and emphasizing recruitment of patients into these studies. And I hope that in the long term, this will also have a positive net effect on neurosurgical research. And finally, there may be other positive aspects of the cultural shifts that are going on when it comes to COVID related research. Potentially, there may be an effect of acceptance of science in society in general. We've seen the impact of, I think this is the first time that a generation has seen how science is leading to direct and immediate differences in their lives, predominantly as it relates to the development of vaccines. But perhaps this will translate to a greater acceptance of science among the general public and a greater willingness to participate in research studies and to help advance other domains of inquiry. And also for clinicians who are perhaps less busy with elective cases, there's been greater time for research and publications. And speaking to Jim Rutka a few weeks ago, he was telling me that the number of submissions to the Journal of Neurosurgery have increased quite dramatically over the last few months as a result of the COVID pandemic. So potentially this can lead to a reorganization of priorities. And if some of that time that's spent doing research as opposed to clinical work remains in that space following the pandemic, I think that could be a major cultural shift within the neurosurgical community. I will say that the story of neurosurgical research is the story of resilience, and it's the story of an entrepreneurial spirit. And within our field, there is a great legacy and a great history of accomplishment despite adversity. And what we've seen at SickKids is the direct and the indirect consequences of the COVID pandemic, but we've also seen changes that I think can have a significant positive impact on research in the long term. With that, really I'd be happy to take questions and hopefully we can have a fruitful discussion about what is happening at other centers around the world. But I very much appreciate the opportunity to talk about our experience, and I look forward to hearing about the experience of others.
Thank you very much, Dr. Ibrahim. That's a very thoughtful presentation, sharing how things are evolving in the Sick Kids Hospital. Questions for Dr. Ibrahim, please. Dr. Harbaugh, do you have any questions for Dr. Ibrahim? And I noted in one of your interviews that you had given you in Penn State, you have still managed to do research during the COVID period. Can you share with us?
Yeah, first, great talk. Thank you for that. This has been a challenging time. One of the things we did, our College of Medicine did, is to say if there are research efforts going on that we view as essential, in other words, if we shut them down, it would be nearly impossible to restart them, that those investigators could continue to come into the lab and work on those projects. From a clinical trial standpoint, if someone was coming into the institution simply because of a clinical trial, that was stopped. But people who were coming in for care and a clinical trial was part of that, that could continue. So we did continue the research efforts even during the height of the pandemic, and that seemed to be done safely. The observation that there's been a real shift of research funds toward anything infectious disease, and particularly COVID, is not confined to Canada. Our National Institute of Health has had the same approach. One of our faculty members, pediatric neurosurgeon Steve Schiff, who's been doing a lot of work in East Africa with the infectious causes of hydrocephalus, actually had an opportunity to take some of the substantial infrastructure he's built up for that and kind of twist it a little bit to look at COVID. So submitted a number of grants over the last few months that has that infectious disease focus. So exactly where this is going to come out in the long run, I think it's hard for people to predict. But I agree with all of the observations Dr. Ibrahim made that it's really changed the landscape.
Thank you, Dr. Harbaugh. Dr. Boop, how is I know that St. Jude is pretty much of a research hospital, neuro-oncology. And I know you are co-director of the Neurosciences Research Institute. How are things in Memphis, research-wise? Thanks.
Yeah, Naren, they have initially shut the doors to bringing in new patients for about 2 months. And now they're bringing in protocol patients only. They do nasal swabs on each of their nurses every other day, each of their patients every other day, inpatients, and the physicians once every 4 days. So it's a very secure place, but they've limited the number of patients that they'll bring in.
Thanks. Thank you very much. I think in Birmingham, Mr. Walsh can correct me once again, the research has been mainly until about the beginning of August only for COVID. And then since then, they have been allowing for new applications for ethics for other research. Mr. Walsh, do you want to make any comments, please? Thanks.
No, I think I agree with you. I mean, the research has pretty well shut down and is now just beginning to come back. There's been a number of sort of national initiatives on relating to COVID, which the hospitals participated in, but outside COVID research, I think very little has happened up until very recently.
Thanks.
Naren?
Yes, Professor Zanon.
Yes, just a comment. Congratulations, Ibrahim. Also in São Paulo, the good things for research, it was IRB allowed us to reach the consensus form by phone or by internet. There was more rapid answer. And with the neurology, we got the opportunity to implement a new protocol, research protocol, to see the waveforms similar to ICP monitoring for COVID and non-COVID patients. It was the opportunity to work without surgery at this moment. For us, it was a great opportunity to move to research, because before COVID time, it was only assistance, almost zero research.
Thank you. Professor Arraez, how are things in Malaga and Spain research-wise? Are they?
Okay. Well, we have been going through the difficulties of, you can imagine, because the priority of my hospital were just look after the patient with COVID. Actually, the main building of the general hospital was completely converted into a COVID center, and all the surgical specialties went out. And I have to mention that for several months, it has been the priority. We had several projects, one of them, the building of a cadaveric laboratory for training and we have to stop that for a while. And hopefully this September, at the beginning of September, I'm going to try to retry that, you know. But it has been a difficult period with many of the project stopped. But this is true, and I like to see in the presentation of Dr. Ibrahim, I like to hear the comment from Professor Rutka, according to which, due to this time in that many people has been locked down, we had more time to be, let's say, devoted to those papers not completely finished and all these sort of things. And in some way, what has been based in the work at home during the lockdown, the lockdown has been improved. But any project, we had a project of nanotechnology in brain tumor, everything has been completely stopped. This is our experience.
Thank you very much. Dr. Ibrahim, do you want to make any comments before? Thanks.
No, I only to thank you very much for including me on this in this really wonderful symposium, and congratulations for bringing it together. Thank you very much.
Thank you. Thank you very much, Dr. Ibrahim. Now it's my pleasure, privilege, honor. It's too many words to say to Dr. Harbaugh. Dr. Harbaugh has, I have known Dr. Harbaugh since 2005, and it's very unusual that we go without a week without emailing, and Dr. Harbaugh has been a great supporter for me. Dr. Radka had introduced me to Dr. Harbaugh when I initially proposed running a web-based conference. Dr. Harbaugh is a huge figure in neurosurgery and an immense figure in American neurosurgery. He's the professor and chairman of the Department of Neurosurgery at Penn State. He had come from Brown before that, and he was the president of the American Association of Neurosurgeons, and also the senior society, the Society of Neurosurgeons. Professor Harbaugh is a very distinguished vascular neurosurgeon with a cadre of his fellows who are now at high places in many of the centers, but he actually started as a pediatric neurosurgeon, which brings him to our, I'm proud of that. But Professor Harbaugh is more than that. He's been a very influential person in the American neurosurgery. In many ways, he has put American neurosurgery into a different orbit with his the national outcomes data, world initiatives, and also has been an advocate of the neurosurgery in the Congress and the Senate, and also in Penn State as well. He's the vice president of the Penn State Health System. And for me, for any project that I do, I always call Dr. Harbaugh, and he has always supported me, and he had kindly made me adjunct faculty of his department, which has made many of the projects that I do possible. So Dr. Harbaugh deserved all that long introduction. Thank you very much for being with us. Thank you.
Well, thank you for that very kind introduction. I'm going to try to share my screen.
I shall. Great, thank you.
Can you see my presentation?
Yes, and Dr.
Okay.
Harbaugh has been the czar for COVID at Penn State Health System as well, which is the most relevant as well. Thank you, sir.
So thanks again, and as Naren indicated, this is going to shift gears a little bit. One of my roles at Penn State is as the senior vice president for our academic part of the health system. And so I was given the dubious honor of being asked to serve as the medical director for our academic medical center response to COVID-19. So I learned a lot about things I had hoped never to have to learn anything about. So this presentation is not going to be as much neurosurgery specific as a presentation from the perspective of an academic medical center and health system. So we've learned a lot. If you think about it, the first tracing of patients that started in Wuhan at the end of December of last year. The first patient in the United States, January 20th in Washington State. Travel out of Wuhan was suspended on the 23rd. So I mean, we've really only had about 7 months of experience with how to manage the COVID-19 pandemic. At Penn State, we saw a peak in our number of cases the last week of April. We saw the bottom in our number of cases in the first 3 weeks of July. And I think we're already seeing something of a second wave as the restrictions on businesses and gatherings have loosened in Pennsylvania. We've seen an uptick in the number of cases. And now for the last several weeks, we've been at about 35 to 40% of the peak. And that's been very stable. And what I'm going to focus on here is how different our response is at this point to what it was initially in January and March when we saw an overwhelming epidemic approaching us. I think our response has been quite good. Our mortality rate for everyone in the Penn State Health System who's tested positive for COVID and been treated here, this is inpatient and outpatient, is a little less than 1%. Mortality rate for our academic medical center is about the same, but a little better. We have two hospitals where we focused all of the COVID patients. One is our academic medical center, one is a community center. For much of the pandemic, the last few months, our community center actually had more patients. They were hit harder than our academic medical center, and they handled almost all of them well. We took 4 transfers from the community center, but most were handled well there. The organization we used, and what I'm going to do is kind of go through what we did in response to the initial surge, and then talk about things that we might do differently and are doing differently at present. So when we first started to get ready for the pandemic, we set up an incident command center to coordinate the planning and response. And those were actually 3 centers, one for our academic medical center, one for our community hospital, and then one for the health system overall. I was the chief medical officer for our academic medical center. We set up specialty-specific teams. These were COVID treatment teams who actually took care of the patients in the ICU and on the floor, and then teams for surgery, primary care, hospitalists, critical care, and others as needed. Those organizations evolved a good deal over the 3 months that we were dealing with this, the first 3 months. And, you know, we've put them in abeyance right now. We no longer have these incident command centers set up, but all of those organizations know who's involved and they're ready to be reactivated if needed. Our goal here is that, one, COVID's not going away. We're going to have to learn how to take care of COVID patients along with all of our other patients. The idea that we can somehow quit taking care of all of our other patients just to focus on COVID is not a good long-term solution. So what we're trying to do now is move this into saying COVID will be with us. How do we care for these patients and still do all the other things we need to do? The issues that we faced initially, flattening the curve, you know, those are really public health issues and beyond our control. We do try to influence our state government in regard to their edicts, but often not very effectively. And just an observation is that, you know, flattening the curve does not change the total number of patients that will be effective. It just lowers the peak. It's the area under the curve that represents the total number of patients. So unless an effective treatment or vaccine becomes available, flattening the curve will not change the total number of patients affected. It will simply spread it out over a longer period of time. So in preparing for another surge, one of the things that really worried us at the start of this pandemic was we didn't have enough personal protective gear. And so that personal protective equipment, we've stockpiled a good deal of that. We're much better prepared. And that involves things like masks, face shields, gloves, gowns, etc. And although the supply chain remains somewhat unstable, we're in much better position now with that than we were when this started. One observation is that people have done some things that are really not very evidence-based. One of those is the use of N95 masks. Theoretically, N95 masks should be more effective than regular ear loop masks or surgical masks. but the data to support that are basically non-existent. If you actually look, there are 3 good meta-analyses and 1 randomized trial comparing N95 mask to standard loop mask for other respiratory viruses, not for COVID-19. And there's no difference between the standard mask and the N95 mask in regard to clinical effectiveness. Anyone who's interested, I'll be happy to share those studies. In preserving our capacity for inpatient care, we came up with a surge plan for how we would use ICU beds, negative pressure rooms, ventilators, ECMO, et cetera. And that plan is still in place, but in reviewing that, our feeling is that we probably overreacted to the first surge. Everyone was truly scared. They saw what had happened in Milan, they saw what had happened in New York City, and so people were really very, very concerned, and I think we overreacted a bit. We've learned a lot since then. We do have a tiered plan for surgical cases, but as for many things, I don't think we would react as drastically. We dropped our OR cases to 25% of their baseline. It was basically just urgent and emergent cases. At present, we're actually back up to more than 100% of our baseline OR cases, both for neurosurgery and for the OR as a whole. We're getting, some of the backlog taken care of. And it shows, I mean, we're able to do that, maintain our PPE, keep adequate resources for the COVID population. So I don't think we would react with quite as much panic, if you will, as we did the first time. Reducing patient and provider exposures, we reacted with travel restrictions. We really ramped up our virtual consultations. We made more progress in virtual visits in a month than we had made in the previous 3 years. One of the things we're seeing now is as the pandemic is receding in this area, is that there are an awful lot of patients who do not want virtual consultations. Everybody's offered that. People are given their choice. And most of the patients still want to come in and actually see the physician. We've done a lot with telecommuting. We've really reduced the number of employees who are on campus and people who can do their job from home are being encouraged to do that, and that seems to be working well. We did have a no visitor policy, and that was really tough on the patients. And so we've decided that's not appropriate. We don't give up all of the things we learned about taking care of patients because of this virus. So, patients are allowed a visitor, a support person to be with them during their hospital stay. And we've also found that social distancing in clinical settings has really never been possible. We can say we do it, but we can't. There's not available room in the clinics, available room in the hospital rooms where we take care of the patients. And that, one of the things we've learned is after taking care of hundreds of patients who are definitely COVID positive in a confined space in a hospital room, we have not had one employee, doctor, nurse, technician, who we've been able to document transmission of COVID because of taking care of them. And they were certainly not socially distanced. So face mask, face shield, gown, gloves, good hand hygiene are very, very effective at preventing transmission. And that's something I think that has really reassured our employees that they can come to work and take care of these patients safely. At present, we are testing all our patients before surgery. Initially, that had to be done within 3 days. We've extended it now to 5 days. I really question its value. And I'll show you a little data on that in a second. And at present, we treat any untested patients as COVID-19 positive, and that involves different protocols than those who have tested negative in regard to PPE, room cleaning, use of negative pressure rooms. And again, I doubt the wisdom of this. I think our standard PPE, standard protocols are very effective at preventing transmission. We don't have to go to N95 masks and negative pressure rooms and all of those other things that we do if we don't know the test result or if the patient tests positive. The one exception to that from a neurosurgical ENT perspective, I think, is likely anterior skull-base surgery, where drilling in the sinuses can really cause massive aerosolization of virus. So that may be the exception. And those are the cases where I think any increase in precautions, N95 masks, PAPRs, et cetera, can probably be justified. So here's the results of our labs. Again, these are all of the COVID-19 labs done pre-op for the last couple of months. And you can see the percent positive is less than half of 1%. And some of those positives are false positives. You have to ask the question, is making the patient come in for pre-op testing really of value if we simply assumed that all of the patients are negative but use standard PPE and precautions for everybody we treat surgically? I don't think we would see any change in our infection rate. And the question is being discussed now, is this really a good use of resources to do all this testing? I suspect it's not. The other thing we found is that our in-house testing, if we look at the positivity rate, and we're very confident about the quality of those tests, it's about a third of the positivity rate of the commercial labs. So the commercial labs, I think, are erring on the side of reporting things that are positive that we probably wouldn't. So some of the things we've learned, epidemiology, when we look at transmission, as I said, we've had no documented cases of our personnel becoming infected from caring for patients. The ones who've become infected almost uniformly become infected in the community or at home. So prolonged close contact, confinement in crowds seem to be where this virus really gets going. The other thing we found is, again, with our own personnel and our patients, is most people who contract the virus are not very ill. They get sick, but they get sick briefly, and they seem to make good recovery. The mortality is less than 1%. And there are really susceptible populations. In Pennsylvania, the average age of death from coronavirus is 80 years old. About 2/3 are from extended care facilities, nursing homes, etc. No one's completely safe, but elderly people, people with underlying medical conditions are certainly at much, much higher risk than younger and basically healthy people. What we've learned about management is our processes and routine PPE are effective. And I think that's gone a long way to making people feel more comfortable working in a healthcare environment and coming to see our physicians. The treatment for this, we've learned a lot, and it turns out to be unlike other respiratory virus infections. We've learned a lot about the immunological response pathology, things like a cytokine storm that seem to be a cause of some of the most severe cases of this. We've learned that early intubation is really a concern. I think one of the things that happened in New York City is patients would come in with low blood oxygen levels. They didn't seem to be terribly sick, but somebody whose PO2 is at that level, the standard treatment was to get them intubated quickly. Turns out that's probably a mistake. The people who get intubated seem to have a much more difficult time. And we're learning how to use things like anticoagulation, steroids, other modifiers of the immune response that I think may be of value and will reduce the mortality for this. I suspect there are other treatment options that are going to come out in the near future that may also help make people a little less worried that if they get COVID, it's a death sentence. So overall, I think what we've learned is you really have to respect this virus. If you treat it like any other virus, or this isn't really a problem, or we can quit worrying about this, you're going to have very bad problems. On the other hand, I don't think we need to fear this virus. What I try to make the point of in our health system is trains can go off the tracks in two directions. And I think our initial response, we went off the tracks a bit in one direction. We closed down more than we needed to. We denied care to people who needed it because of our concerns. We handicapped ourselves. The response to that isn't to say we don't have to worry about the virus, we don't have to respect it, but I think we need respect, but we don't fear the virus. And I think if there is a second wave, we'll be in a much better position to deal with that than we were a few months ago. Thank you for the opportunity.
Thank you very much, Dr. Harbaugh. I think as you mentioned, that we will be in a better place to respond to the second wave than we had been. And questions from the floor, please. Thanks.
So Bob, I had a teenager with a large craniopharyngioma a couple weeks ago that turned up positive the day before. We canceled surgery and he ran fever and had some diarrhea for 2 days and then was asymptomatic, but 2 weeks later was still positive by nasal swab. And because he was losing vision, we ended up operating on him as positive, wearing all the PPE. But how are you handling patients who have persistently positive cultures?
Yeah, the persistently positive cultures are meaningless because most of the best testing is PCR testing. So any fragment of RNA that's left there will test positive. It doesn't mean that those people have active virus particles. So we've basically given up repeat testing. If someone tests positive, they get their surgery postponed. If they can, they get their surgery postponed for a couple of weeks. If an employee tests positive, they get their, they quarantine for 9 days. So to retest them really doesn't add anything, doesn't mean anything.
Dr. Harbaugh, in terms of the accuracy of these tests, where are we in terms of accuracy? Are they pretty watertight?
Well, that's the thing, Aaron. So the PCR test has both very good sensitivity and the specificity. And so from that standpoint, it's very good. But even though the sensitivity of the PCR is probably about 98%, as you know, the positive predictive value for any diagnostic test, it's sensitivity, specificity, and prevalence of disease in the population. So if the prevalence of the virus in the population is really 50%, so take a symptomatic group, and you get a positive test, you're almost certain that person is truly positive. On the other hand, if the prevalence of the virus in the population is very low, as our testing suggested it is, most of the positive tests, even though the sensitivity and specificity are good, most of the positive tests will be false positives. And so that prevalence piece is something people don't think about when they look at the predictive accuracy of the test. So I think what we've been worried about is to make sure we don't miss a positive test. So we treat all positives as positives. But honestly, looking at the prevalence of the virus in our population, I suspect at least half of our positive tests are false positives.
Thank you very much. Any question from Girish to?
Yes, thank you so much for this wonderful presentation. So some of it kind of overlaps with what I was going to talk. So I have a question for you, Bob. In terms of developing space to allow surgery to occur during the winter, because we all know about winter pressures. I'm sure there's the same thing in in the US. Do you have a strategy that allows for increase in bed capacity and intensive care capacity that will protect neurosurgical activity?
Yeah, so we do continue to have COVID units. We have 25 beds right now that are designated for COVID. We're averaging about 15 of those in service at any time, so we have a little bit of leeway. The surgical services have been prioritized for the other beds, so that we need to make sure we can continue to do our elective surgical cases just from a financial survival standpoint. One of the things that we're doing, anticipating the flu season that's coming, is we're asking that all of our primary care sites have evening sessions for acute respiratory illness, not COVID, but any acute respiratory symptoms, so that patients can come in at the end of the day with those acute symptoms, be evaluated, tested as needed. And again, the goal here is, I think when this first started, we said we have to focus on COVID and make that something separate from everything else, and this is how we respond. And what we're seeing now is we can't do that unless this is going to go away soon, and I doubt it will. We have to figure out, how do we take care of patients who may or may not have COVID? How do we do that while we take care of all of our other patients as well? And I think we're certainly getting better at that, and that's what we're planning for the fall and winter.
Thank you.
Thank you very much, Dr. Harbaugh. I'm most grateful for your excellent lecture and for the time. So I'm now going to move to Mr. Girish Solanki. It's my pleasure, and Mr. Solanki, as you know, is one of my senior colleagues at Birmingham Children's Hospital. He sits just over maybe 2 meters away from me, so it's really for me to sit next to him and pick his brains in terms of clinical as well as eavesdrop on all his leadership side of things is very, very instructive to me. He's also the chairman of the British Paediatric Neurosurgery Group, and Mr. Solanki has imagination and lateral thinking, and which I have benefited learning from him for a long time. But at this time, he's in the right place for the right person is at the right place. And I wonder what's his plans for the British Paediatric Neurosurgery Group for the coming challenges. Thank you, sir.
You put me in a difficult position now, Naren.
Thank you. You're welcome.
Thank you so much for your kind introduction. I think that I probably pick up more lateral thinking from you than you from me. So it's been a useful sort of a collaboration in that room. So again, thank you for organizing this wonderful seminar. I think, so much positivity coming out. You've asked me to talk about the role of a National Pediatric Neurosurgery Society. So I'm going to start by saying that we are actually a group rather than a society. And I will try my best to kind of give you some feedback about what the BPNG has done, and also what I, in my role as a chair, had to do to keep the whole sort of national program for pediatric neurosurgery during COVID-19 running. Okay, so I think it's stuck already. Are you seeing my presentation?
Yes, yes.
You can see it?
Yeah.
Okay, perfect, lovely.
Good.
So I will start by saying that this is definitely not a singular effort, not even of one single group, but a number of acronyms there, BPNG, FEBNS, FRCS, NHS, PHE. So of course, most of these are familiar to all of you. The British Paediatric Neurosurgery Group is a subspecialty of the Society of British Neurological Surgeons, which works very closely with the Royal College of Surgeons. And of course, we all work in the National Health Service. And we, during COVID-19, the public health, not education, sorry, the public health department has been, a Public Health England department has been instrumental in guiding us, in keeping us safe, for good or for worse, I should say, during the whole COVID-19 pandemic. So the British Paediatric Neurosurgery Group is only 87 active neurosurgeons in the United Kingdom and Ireland. We are a subspecialty group of the SPNS. The chair of the BPNG sits on the SPNS Council, represents the group's interests, and this is how we work in the UK. The NICE, of course, is the National Institute of Clinical Excellence, and they provide guidance as well to pretty much all the surgical and non-surgical specialties. So what was the role of the BPNG? I think I would start by saying that the first thing as we went into lockdown, actually had just been elected chair, I think a few days before lockdown. And as we went into lockdown, I think it was my sort of particular interest, as Professor Harbaugh mentioned, to create a command and control center so that we knew the lines of communication and where the information was coming from and how to send it downstream. So I worked very closely with the SPNS president and secretary. I pretty much was on the phone with them in the beginning, often every other day, and then weekly. And that allowed me to remain very much part of all the developments that were occurring. I formed, because the NHS had allowed us access to social media during the COVID pandemic, we were able to set up a rapid response group on forming a WhatsApp group. And that was made up of all the clinical service leads of all the pediatric neurosurgery units in the United Kingdom. That means the 4 countries and Ireland. So everyone in the British Isles was connected through a rapid means of communication. And we kept in touch with the Royal College of Surgeons who wanted to get specialty guidelines, and we provided those. We kept in touch with the commissioning groups, which is probably something that other countries don't have, but in the UK, clinical reference groups decide on, for example, women's and children's services, and they then provide both the authorization and the funding for services to be developed within regions. And also, we also worked very closely with the pediatric surgical specialties so that we would work all in tandem. And for me, it was all learn. I mean, you know, COVID-19 just came to us like a bullet. So I spent a lot of my time reading about how to, you know, stay safe, how to keep my colleagues safe, how to keep our patients safe, how to create a safe environment. And as I said, Public Health England was very instrumental in providing this guidance in a timely fashion. I think they did an enormous job doing this. And of course, we were also asked to provide guidance. So the first one that I received an urgent request was we need to define, for example, what are the pediatric neurosurgical conditions that we consider as immediate, that need to be operated within 72 hours, within 4 weeks, 3 months, over 3 months. And this was an exercise that allowed us then to develop a national guidance for the whole of the country for which conditions we would recognize nationally as needing surgery so that all units would then accept that. And that then led to our role as, so our first role was to learn, our second role was as advisory. We very quickly developed our first pediatric neurosurgery guidelines by the end of the month. And that was then published through the various societies and the Royal College of Surgeons and put up on the NHS sites as well. So everybody had access to that. Now, how did we do this? Of course, initially we very quickly put things together, but the requirement was really that these guidelines had to be robust, had to be accepted by the majority of the pediatric neurosurgery group nationally for them to be accepted. So what we did is, again, we use a rapid response group to get feedback and create the guidelines. And then I used the panel of the past 4 chairs. Richard, of course, who is in the group of faculty today, is one of the past chairs of the BPNG. The other chairs being Rich Edwards, Ian Kamali, Donald MacArthur, and the current chair myself, plus the chair of the SPNS, to review the guidelines and then ratify them and then put them out. So this allowed us to develop a robust methodology to provide national guidance for pediatric neurosurgery, which was well accepted and then followed as well, which was really great for us. The problem, of course, was that as soon as you put the guidelines out, you needed to revise them. So by the end of the first month, we had to come up with the revision as things were changing so fast, and the evidence was changing with it, and we had to make recommendations. Not only that, but then the other societies like Pediatric Neurosciences, working through the commission groups, also wanted our feedback and wanted to put that on their guidelines. And the children's surgery, which is about 30 surgical specialties, also wanted to share our guidelines. So we were constantly working with them, trying to ensure that whatever advice we were giving was consistent, was the same across the board, that we had our links updated at all times. And gradually we started coming to a situation where there was some stability in recognizing, for example, how would you treat hydrocephalus during COVID. And it was very clear that we needed to keep everything simple, and that patients that we couldn't see needed to have a mechanism to remain safe and have some monitoring done. Same applied to oncological surgery, devices that we had implanted whose batteries were running out, or lungs are beeping. So all of the stuff needed to be dealt with, and we had to provide guidance. So we started putting out appendices of providing guidance so that communities where, for example, there was no pediatric neurosurgery would be able to refer to neurosurgeons, knowing that these are the sort of things that we need to do. And they look very simple, and for us it's bread and butter, but those guidelines allowed access to non-neurosurgeons or areas where this could be used by GPs and other places. For us as neurosurgeons, we also wanted some guidance about, okay, what am I going to tell my hospital, for example, which are the conditions that I absolutely need to operate and take priority over everything else. And so we created this list of surgical procedures, joined them up with adult neurosurgeons, and this was then accepted by the children's services and the neurosurgeons, and this then became official guidance for a list of procedures. And the BPNG Rapid Response Group was also extremely instrumental for us because we were then able to communicate with everybody in a regular basis. There was a little bit of banter, which I tried to keep to the minimum. Sometimes I succeeded, sometimes I did not. But that group allowed us to know on a weekly basis what was happening across the country. So I set up a mechanism to receive weekly reports of activity from every clinical service lead, or what you would call in other places, heads of department, to provide me with information on staff, levels of staff, levels of sickness, deployment, capacity, number of surgery being carried out, emergency surgery, elective surgery, reduction in surgery. So I got a lot of information that gave us some idea about whether units were having difficulty, for example, admitting patients into intensive care units, or were they able to continue to operate successfully, or did they need some support? And all of that allowed us to remain as a cohesive group supporting each other. The British Pediatric Neurosurgery Group has data that we've been collecting for the last 14, 15 years. This is a sort of a graph showing operative activity. And we know from our data of many years that generally speaking, about 53% of our activity is emergency and 47% is elective. So we had data that we could use to compare with what was happening during COVID. So this is again graphs showing percentages of activity in 2018 and 19. And you can see the activity is increasing. So we had data that we could use to compare with what was happening during the lockdown. So the lockdown started in the middle of October. And what we did is we then compared the activity from the weeks of 6 to 12 and the subsequent week, which is another graph. But basically, we looked at national activity. And what you can see here is that there was a weekly overall reduction of about 51% in the activity. And even emergency surgery came down by 15%, which was really strange. But it also represented the fact that patients or the parents were anxious about bringing their children to the hospital, where in other situations they might have. When we looked by breakdown, I'm just going to move this up. By breakdown, you can see that there was this is all overall reduction. So surgical demand, 51%. Trauma was reduced by 80%. So that was one of the benefits of the lockdown, was that because there was no cars on the road, trauma, particularly cranial trauma, reduced by as much as 80%. Vascular, pretty much everything was down, apart from infections, which did not change. Dystrophic cases went down by 60%. And I wondered at some stage whether the deliveries where patients are being advised termination for some of the conditions. Of course, we could never collect that data. But also the other interesting thing was a reduction in hydrocephalus, so acute block shunts reduced by 45%, clearly suggesting that children with symptoms were probably not presenting in a timely fashion. And when we compared with our overall operative data, there was a reduction 51% in overall surgical activity. So that's the sort of thing that the national society can do to keep abreast at the national level of what's going on in the country for your own specialty. And then one of the things we discovered by doing this was that there was a significant reduction in the presentation of children. So, you know, where is the sick child? The sick surgical child had nearly disappeared in some areas of activity. And this, of course, created immediate concern and led to the NHS campaign to get children and patients back to seek medical care in an urgent basis. And I think the feedback that we provided from neurosurgery was instrumental in recognizing that oncology patients were presenting late, shunt blocks were presenting late, and we all had experience of that. So the other thing that I want to tell you about is that as a specialty society or group, we often get involved in national strategy. So one of the things that happened was a strategy that the UK had set up called the Operational Pressures Escalation. That's OPEL strategy. And that strategy was essentially to set up a plan, a background plan that in case there was a massive surge in COVID patients that overwhelmed all the intensive therapy units in the country, what could we do to create additional space? You know, so we needed to be ready if there was such a catastrophic situation, and we needed to have a plan. So a plan had been put in place, which was essentially meant to increase adult intensive therapy unit capacity. And that was to be achieved by basically taking away pediatric intensive care beds from a number of units and centralizing pediatric intensive care activity in other units. For example, standalone pediatric hospitals who get to take all the pediatric intensive care patients from mixed hospitals so that the intensive care units in the mixed hospitals could admit adult patients. And there was a shift as well, a planned shift of specialists from pediatric units to adult units to deal with any such catastrophic surge. So there was this plan, and at the highest level of the plan, essentially all of the pediatric beds would disappear in a number of hospitals and would be centralized in other hospitals. Now, this to us seemed a catastrophic plan in pediatric neurosurgery because you can't really move children which are very young from hospital to hospital. And particularly if you need life-saving surgery within 1 hour, you have to do it in the hospital where the neurosurgeon is. And then to transfer a patient who is being operated like that could be life-threatening. So we then were able to provide such feedback to the BPNG, to the National Planning Program. And as a result of that, the pediatric component of that escalation was abandoned. And fortunately, as you all know, there weren't any significant, significant increases in pediatric cases to actually create a shortage of pediatric PICU beds. So that was a real close shave for us. I think I'll just briefly mention something that's happening in the UK and might be happening in other countries as well, getting it right first time. So this is some program that is supported by the Society of Pediatric Neurosurgeons. And the idea is that we do a national audit of our activity, not just within the department or within the hospital, but a national review of practices so that we get it right first time, reduce complications, reduce mortality, improve efficiencies, become more effective in what we do. And I think this has been very instrumental in us understanding where we can make things better, quicker, more efficient. And that also was helpful during COVID. So 24 hospitals across England conducted, for example, cranial neurosurgery. I'll talk a little bit more about spinal neurosurgery afterwards, but that was a review of 75,000 neurosurgery cases per year. They identified that 40% were emergency admissions. These are mostly adult patients, and pediatric GERF is going on at the moment. The length of stay typically is longer in neurosurgery because of trauma and other things requiring prolonged recovery, oncology, and so on. And so what they did is, after looking at all this data, and I'm not going to go into details because I just want to tell you what are the things that as a society we can do, they came up with guidance. So for example, they made 15 recommendations in the case of cranial neurosurgery. And those 15 recommendations have provided an opportunity for us to look at during COVID and how we could reduce the number of days in hospital, how we could reduce the utilization of PICU beds, how we could optimize, for example, the use of operating theaters. So all of that came in really handy. And I certainly learned some lessons from looking at what my colleagues were doing around the country and how we could take some of those good practices into our own practice. Similarly, there was a spinal get it right first time, spinal surgery, again, 22 recommendations made. So all of this had already been happening in the UK, and I think it helped us to get better perspective on how to get our surgical procedures going. So now looking at this management of elective surgical procedures. Now, as Professor Harbaugh mentioned, what happened in March and April is quite different from what's happening now. And at the time, we all sat down together, we identified the list of procedures that needed to be treated as emergency. And then we had to go through our elective surgical lists and categorize all patients into 5 COVID-19 grades. That meant that grade 5 required immediate surgery, grade 4 required surgery urgently, and all the other grades were either elective or semi-elective. So all elective surgical lists were suspended in the UK. Emergency lists were activated, and the plan was really to identify those patients that needed to go into those emergency lists. And then everybody else, either we went for an outright cancellation, postponement for 3 to 6 months, or reduction of the surgical procedure to its minimum required, so that we would reduce bed utilization, ICU requirements, and then ensure that each hospital had the capacity to support a certain rise in critical ill patients. We talked about the OPL escalation, minimize the use of PICU beds specifically to post-op cases, so use HDU instead. So the intention was that PICU was critically needed at that time for COVID-19 deteriorating patients, and everything else took second place. And of course, we then had to also ensure adequate protective, personal protective equipment, ventilators, level 2 non-invasive ventilation. And so all of that was happening simultaneously to ensure that we were able to run a good, safe surgical practice. And then when it came to the management of the emergency surgical procedures, the issues, of course, were that there are hardly any lists, and we had to share the lists with other surgical specialties, so 30 surgical specialties vying to use maybe 2 or 3 surgical lists per day. The anesthetic workforce had been deployed to ITUs and other places, so it was always quite a significant problem to actually get scrub staff, anesthetists, to run those lists. So it was quite a difficult situation, and we were absolutely doing the minimum emergency requirements at that time. And then, of course, there was concern about the aerosol generating procedures. Other speakers have spoken about this before. So using full PPE slowed down the surgery and, of course, delayed each procedure to the point that it became quite difficult for us to run, optimize our surgical capacity. So we had to triage, we had to do hospital level prioritization of all pediatric surgery cases, not just neurosurgery, but others. We had to have a panel of managers, surgeons, anesthetists that then decided at the hospital level which patients had to be operated on which day. So they're quite tough decisions because the resources were scarce between specialties. But overall, there was a consensus, and review of published national guidelines allowed us to make our cases forcefully. The Royal College of Surgeons then provided some guidance for recovery of surgical services. And as Professor Harbaugh said, we are now getting in many countries to the stage of recovery. And the stage of recovery requires us to start elective surgery in a safe fashion. So it's extremely important that we do this, first of all, by reviewing patients that we have not seen for a while. To do that, we have to prepare the outpatient activity. We have to build the space and capacity for face-to-face reviews. We have to build an IT structure to support telephone and video consultations. We have to agree to a minimum time so that there is adequate airflow in the rooms where we are carrying out the clinics, create social distancing, masks. So all of that has to be put in place before we actually restart outpatient activity. But restarting, we must, otherwise more problems will accrue to our patients. Equally, when it comes to bringing those patients in, we need to have the ward capacity and strategy. Do we have separation of what we call the green areas where COVID-19 patients are protected? Do we have access to private hospitals where we can increase capacity? We don't have, for example, but a lot of countries have quite significant private pediatric neurosurgery practice. So using the private facilities will definitely increase their capacity to carry out more surgery. And the COVID-19 negative patient area is the area where we can carry out most of our activities in a safe manner, and that ensure that in that area we have facilities such as physiotherapy and rehabilitation facilities. Ensure that as we plan to go back into elective services, that allied specialties like speech and language therapy, occupational therapy, physiotherapy, all the other specialties become available so that when patients come in, they have an optimized pathway where everything is provided very, very effectively, promptly, and they can be discharged in very little time. And so the Royal College of Surgeons has mandated all hospitals to go through a checklist. So if the checklist is not met, they don't recommend that they start elective surgery. And the most important question that is asked is there evidence of sustained reduction in the rate of new COVID-19 patients in your trust for a period of time of at least 14 to 21 days past the peak to ensure necessary staff and associated facilities, including ITU, are available? And that means that we don't really want to restart elective services if your area is still affected by potential surges that may disrupt elective surgery. and that emergency surgery may still take the majority of your surgical capacity. So elective surgery can only start when you have dealt with all of your emergency activity, and you now have spare capacity to start elective activity. And when you start elective activity, of course, you need to know how you're going to do the testing, isolation, especially high-risk patients. How's your negative COVID-19 negative area set up, operating theaters, anesthetic rooms. All of this is bread and butter for us, and most of us have already done this. But nevertheless, when you plan and strategize, these are the steps that you must ensure that you have gone through. Otherwise, you're bound to fail or get into serious difficulties, and then it's like a false start, and then you have to restart again. And of course, when you start elective activity, everybody will be calling you to have their surgeries done. So you need to ensure that you've identified the long waiters, those needing surgery first, identify how long the surgery is going to take, because remember, you'll be using personal protection, which will delay the surgery. Is there an accurate assessment of the surgical workload by specialty? How many patients in neurosurgery need to be done? How much time am I going to need? Is the hospital going to provide me with that amount of time? So all of those things go into your equation in planning a return to elective surgery. And then, of course, the final part of this presentation is the second wave and winter planning. So as Professor Harbaugh said, this is the major headache everybody's facing around the world now. Another winter is on the way. And we know that seasonal winter pressures occur in pretty much every country in the world that faces winter. But we also have the worry of a second wave, that COVID may be coming back. So what are we going to do? So the first thing we have done in pediatric neurosurgery is to look at what happens during a normal winter. So to do that, for example, what I did is we looked at 10 years, or it's actually 11 years, of our Birmingham Children's Hospital data. And you can see that this is, we have a database of referrals. So every referral since 2009 has been recorded. It's on a digital database. And if you look at this is a review of 10,000 children. You can see the pattern of referrals. And the pattern of referrals means that in October, November, December, the number of patients, actually, the number of referrals drops. And in the summer months, May, June, July, it's at its peak. And this is very robust data of 10,000 children over 10 years. So that's a pattern that we are going to deal with. And when we look at summer and winter referral activity, again, you can see that summer activity is significantly greater than the winter activity. And this is from 2009 to 19, so that's good, robust data. And here is the difference. So you can see the difference can be as much as 35% between the summer and winter. And this is probably an outlier, but it could vary from somewhere from 15% to 35%. And what are the main conditions that require intensive care unit? So for us, trauma, tumors, vascular, hydrocephalus, and some spinal conditions, possibly due to the type of surgery that they undergo. So we know which patients are going to need PICU, so we can plan better. And I would like to bring your attention to this report, which Professor Harbaugh might find useful. So this is the Royal College of Emergency Medicine report. It's called the Winter Flow Report. It's a report that is published every year for the last 10 years now. And what they have done is this is a voluntary contribution. So there are 29 units in the country that contribute data for this report. And what we're looking at is nearly 5 million patients that are grouped on this report. So it's very robust data. And what it shows is the third quarter activity every year. So this is data for 2018 and 19, the 13 weeks to 31st of December. So you can see here, starting October 1st to the 5th week of December. This is, for example, acute bed capacity. And you can see every year that the bed capacity in hospitals drops in the 4th and 5th week of December. And some of it is due to staff sicknesses, others due to taking holidays. But whatever the reason, there's a massive drop in acute bed capacity. So that increases the winter flow pressure, because that's also the time when sicknesses, seasonal sicknesses present, but you don't have the beds for it. So that's a huge problem for us. The second thing is that if you look at the third quarter again, from October to December, the bed stock, overall bed stock, is also reduced and has been reducing every year, probably a little bit less than previous years. And there is no flexibility. So when you look at the, can a hospital change the number of beds during the winter? 9 of the 29 units were not able to do any flexibility. And most of the units could probably flex the number of beds by 0 to 5% or up to 10%, but only one unit could increase bed capacity by more than 15%. So we know roughly that these units, that's the number of beds they have, that's the number of beds that they have. They probably won't be able to change during the winter. And then the other thing that this report looked at was delayed transfer of care. So there are patients, once they are admitted, it's very difficult to discharge them during the winter. And something like 1,700 patients or cases end up being delayed in terms of their transfer. And that is about 4.6% as a percentage of the total number of patients. And so, of course, this is one of the targets, that if we can reduce the delayed transfer, we'll be able to get more free beds, we'll be able to admit more patients. And the good news, of course, is year on year, things are getting better, but that improvement is less than 0.1 percentage point. And the worst news that we can have is that during the winter, on the 4th week of winter, canceled elective operations drop significantly. What does that mean? It means that planned operations pretty much disappear. And you can see here that there is a reduction of something like 57%. And one of the explanations given is that patients actually don't want to come and have surgery during Christmas. Most people will take a holiday during Christmas, so the number of planned operations will be reduced. Now, of course, given that we have postponed so many patients, and if there is a second wave, unless that week is kept active, we're going to find extremely difficult to deal with a second wave. So now I take you to the second wave. In the UK, the data is pointing to a second wave. As you can see here, this is your first wave. And by the 10th of August, the number of patients, the new confirmed cases had risen to more than 1,000. And ever since, it has remained over 1,000 for nearly 2 weeks now. So there is some concern after the, a situation where I think the lowest number was, 30 patients or something like that. There's a concern that the number of new cases has risen. And with the winter at our doorsteps, there's a serious worry that this may happen. So everybody's working really hard to avoid that. But one thing that we want to ensure is that during the winter, every year, what would happen is that the surgical services would be reduced or shut down to create medical beds to treat seasonal flu or seasonal winter illnesses. So this year, the Royal College of Emergency Medicine, the Royal College of Pediatrics and Child Health, and the Royal College of Surgeons, the Royal College of Nursing, they all come together and put a statement together saying, we mustn't allow this to happen. Otherwise, urgently need the surgery on patients that have their operations postponed by 3, even 6 months will come to harm. And that surgical capacity has to be dealt in an equal footing to medical admissions to allow continuing surgical activity. So the aim this year in the United Kingdom, particularly for surgical children's surgery, would be to protect surgical capacity. And that to do that, we would have to find innovative solutions, not just within surgery, but also in everything around surgery to create additional capacity to meet the medical demand. So this is why we are feverishly now working on approach to winter planning. And what we're doing is we're using the best possible quality data that we have. We're trying to identify the emergency department flow. And fortunately, we have enormous good data from the Royal College of Emergency Medicine. We're looking at our acute ward bed capacity, pediatric critical care capacity, and how to create level 2 high dependency units, which are non-invasive level intensive cares that will allow patients to be either downscaled or patients who don't need PICU care to be admitted there, increase PICU capacity, background, look at the normal background winter admissions, surgery diagnosis, and try to then work out what would be the PICU capacity and look at particularly how many refusals we had in previous years, because that is what is going to tell us where the PICU capacity gap is and how we can solve that this year. And then look at transfers and everything else that we talked about. So we are already working on using technology that we are using to deal with COVID to, for example, try to ensure that instead of patients showing up in the emergency department, they are dealt with by telephone consultations, access to advice, video consultations, face-to-face even, so that diagnosis, prompt diagnosis and a decision on treatment can be carried out without actually admitting children to hospitals where no surgery is required. So all of that is going on at the moment in terms of planning. We are talking about improving capacity, reducing demand. And the difficulty here is that as a surgeon, you want more space, but the problem is the medics are going to say, well, I need to treat my patients. So we have to work with the medics to increase capacity in the medical sector. That means talk with them about opening up primary care centers, GP practices, providing facilities for community services like physiotherapy so that patients can be discharged home quicker, and then opening up PICUs in hospitals other than your own. For example, we have PICU, but there are several hospitals that have very limited PICU capacity and have no HDU capacity, which is level 2. So if we were to, for example, develop level 2 HDUs in other hospitals, then some of our HDU level patients could be transferred to those hospitals. And that means that we would have then surgical capacity in PICU. So I think we have to look at this as a partnership. We can't just say we are surgeons, that's not my business, and just stay focused in what we're doing, because then we won't get the beds. So we in pediatric neurosciences or pediatric neurosurgery, working with pediatric intensive care to create a combined approach and aim at protecting surgery in children, and particularly neurosurgery. So these are some of the things that we have put forward, and we are negotiating with the commissioners to see how best we can get some of the stuff done. For example, in my region, we're talking about increasing PICU capacity by about 30%, simply by just employing more people, because the physical capacity is there, but there is no staff to run it. For example, increase level 2 high dependency units by developing those in other hospitals so that children with tracheostomies, bronchiolitis could go there instead of coming to the major children's hospital. Increase ward beds so that more space will be available. And then do something called a fast lane corridor. So in many places, like for example, the US, this may be standard, but in the UK where we have an NHS service.
Excuse me, Girish, because of the time.
Oh, okay. I'm finished.
Thank you.
Okay, so this is my last slide, actually. Thanks,
nice.
I didn't realize that. Okay, so the fast lane corridor is probably not an innovation in many countries, but in the UK, the idea is that a patient who needs surgery should come on the day of surgery, undergo all the investigation and treatment, and be operated so that there'll be a very rapid discharge. And the UK government has already put out the advice about increasing surgical capacity in the winter. And my take-home message as chair of a Pediatric Neurosurgery Society is essentially that we need to work together with all societies, hospital, department, develop rapid, robust, and secure communications, talk to other national groups. I learned a lot from talking to the other groups online, stay abreast of developments, act quickly, patience and perseverance, and share information, give your honest feedback, and all will be well. Thank you.
Thank you very much, Mr. Solanki. That's as always, a very thought out, thoughtful, and multifaceted and professional talk. There are questions for you on the chat room. Because of the reasons of time, if I can allow, if you could please answer the questions on the chat room, I'll be most grateful. Is that okay?
No worries, Naren. Thank you.
Thank you very much. But this now brings to our final and important talk from none other than Professor Francisco Salamoa, who is the president of the ISPN. It is a I have known Professor Salamoa for many years now. He has always been a very supportive in international educational projects, and I organized after a evening symposium in Rio 5 years ago. Despite him having a very busy schedule running that ISPN Congress, he kindly found us facilities for that and supported it. So it really is a genuine heartfelt pleasure to invite Professor Salamoa to give his view on how international societies are going to respond. Thank you, sir.
Thank you, Naren. I trying to share my screen.
You see that green button at the
oh, yes, sorry.
no problem. Do you see the green button at the bottom of the screen?
Yes, I've already entered that, but it took me to another screen.
Okay. Yes.
Yes.
We are seeing your screen. The PowerPoint is just behind it. That's it. Yeah. Fantastic.
Okay.
Great. Brilliant. Thank you very much.
Thank you very much. After all the fantastic lectures, I think I don't have too much to add at the current status of COVID-19 around the world and its peculiarities. I'm talking about it. I'm at the risk of being repetitive, and this my first slide is the proof of this. This magnificent picture has been already shown during this presentation. So consider, after Girish Solanki presentation, I ask you to please to consider this just a humble reinforcement of everything that was told till now, this afternoon. There is regarding COVID-19, there is a shortage of specific literature, and although neurosurgical complications are very rare, children are more vulnerable, and especially it's the subset of immunocompromised and children with cardiac and respiratory disease. And the main complications are encephalitis, severe and even bizarre forms of disease, such as Kawasaki-like disease, a systemic thrombotic state, and consequently hemorrhagic and ischemic state as well. Pediatric ICUs, recovery beds, and even operating room were adapted for adult critical care, as has been shown before. I used the cycle of grief as an analogy for what is happening at the moment. We started with the situation of denial of the gravity, of the severity of the COVID that was considered little more than a flu. We went to another stage when it was recognized a dangerous disease that needs social measurement, and we reached now the full acceptance of this situation, and we are now exploring options to reopen and to return back to a normal, to the so-called new normal. I have mentioned also the black swan theory, that were surprising events with major devastating consequences beyond any expectation. There is no black swan anymore. What happened was a prompt reaction of the neurosurgical community with recommendation, guidelines, and protocols that lead to a decision-making process that was exhaustively exposed during this presentation. However, the consequences of all these measures still remain. There was a change of configuration with creation of the COVID dedicated areas. There was a postponement of elective procedure, redeployment of neurosurgical staffs, relocation of resources, and the challenges still remain. We are talking now, we start to talk, Garish let it very clear, we're starting to test the transition and reopening to regular surgical practice and regular outpatient practice. And also, we are thinking about how to recover training and research of our residents and interns. And of course, we are going to have a reallocation of resources to face this new normal situation. There are many problems in transition and reopening. Firstly, because COVID-19 is still evolving with unforeseen consequences, as was already seen. The viral load is very different around the world and may vary from region to region in the same country. There are no guidelines regarding the transition and reopening because it's still too early to think about it. So what is intended to do is a gradual reopening according to the number of cases, always taking into account that cases may spike after reopening, and so we may have to consider a new situation of a circuit break, as was already mentioned. So finally, we have to consider characteristics of the community, such as cultural, social, economics, and individual. And so here you can see what happened about 100 meters from me on the last Sunday. Reopening will require some measures such as sustained reduction of cases for at least 14 days, and hierarchization, a prioritization from urgent to elective, as Girish well stressed, and also local conditions. The ability of the hospital system to treat patients needing hospitalization included pediatric intensive care unit and rapid tests available to all patients and to all health providers. And we have to know that transitions take time and nobody knows exactly when and can safely start with it. What one expects after reopening? Well, there was an paper talking about it. It was based in 4 weeks observation after COVID-19, in which there was an increase in the surgical volume, a prevalence of adult functional epilepsy and brain tumors, a decrease in adult spinal cases, but there was little information about what happened with pediatric patients. In order to reopen office and outpatient patients, a triage is needed with checklist, with body temperature, and other measures Gurish had also mentioned. The use of telemedicine, telephone, and video visits as required and should be used as much as possible. Otherwise, one have to limit in-person consultation as much as possible. And we must have a soft schedule in avoiding crowded waiting rooms and reschedule routine follow-ups whenever possible. COVID-19 pandemic also affected in very important way the training. There was, as already said, a reduced surgery and outpatient activity, which reduced mentorship, with disruption of the clinical trials and researches. And conversely, there was an increase in didactic activity, an increased use of electronic platforms, an increase in use of simulation-based training, and also virtual augmented reality. And here you can see how the residents and interns used his time in this precise moment. Most of them going to clinical research and want to watch in remote didactic lectures, as well as reading and preparing themselves for the board. There was a net impact in the academic year, and a survey about it showed that senior residents are more concerned about career prospects than those that are junior residents. And there remains a question regarding how to compensate the working hours of this resident. So far, we know there is no adequate replacement for operative experience. And as said, when resident, they are in a state of indefinite suspended animation, waiting for something new that one have to discuss with more. We have to discuss more about it. Related to opportunities, it was possible to develop remote work. It was possible that led to improvement in research and also improvement in algorithms and checklists. We are evolving with modern medicine. It was already seen to electronic platforms with apps, with simulations, and etc. And we'll have to learn with the disease and learn with the patient. We have to learn with our mistakes. We have to collaborate, and we have to integrate institutions and societies. We have finally to have a lot of solidarity while leading with this situation. In conclusion, reopening of activity have to be gradual and dependent on the local situation. Currently, there is no universal guideline, and decisions will depend on the moment. Decision-making process will be different from country to country and from region to region. Global collaboration will be needed to establish future directives. And last but not least, we have to prepare for long-term consequences and also for a new plague, as stated Albert Camus, that the plague would wake up their rats and will send them to die in a happy city. Thank you so much for your attention. And Naren, congratulations for one more wonderful symposium. Thank you.
Thank you very much. Thank you very much, Professor Salamoa. Again, very thoughtful, and I think you used probably the word most important of this evening is solidarity, because we might think that this is a virus, but it's actually far more than that. It's actually hitting at all levels of our society, from medicine to livelihood to relationships to there's a number of people's lives devastated, and I think this is a war, and this is something we have to consider, work in solidarity. Mr. Solanki, can I please ask you to comment or questions for Prof. Salamoa, please?
Thank you, Naren. Francisco, a wonderful presentation. I think everything you've said, we're pretty much in 100% agreement. And the most important thing was what you've said is unless we work together in solidarity and share, it will be very difficult for us globally to make an impact. And I think one of the things that I was very, very hopeful that we could do was to develop international guidelines. But you saw the presentations today. We are all in different places. And I think developing a singular international guideline probably is not as useful as developing very robust national guidance that works for the region and for the country and the continent. And I think that's something that I became aware as I was preparing something for the ISPN, that we probably would not be successful because it'll be so different in different places that the guidelines could become meaningless.
Thank you, Girish. Any questions for Professor Salamoa? Do you want to respond? Thank you.
Yes, I just want to say that that is really true. We have to work together because because this is a widespread disease with different peculiarities all around the world. So we have to work together. I think there is no possibility to establish some guidelines at the moment, but as I said, I hope we learn too many with the COVID-19, and that we in the near future, we reach some consensus regarding things that are not very clear until now. Thank you, Girish, for your comments.
Thank you very much, Professor Salamoa. As we come to the end of this symposium, may I please invite Professor Nelci Zanon to give us closing remarks on the evening's proceedings. Thank you, Professor Zanon.
Thank you, Naren. Congratulations for this very, very interesting online seminar. We learn, we teach, and excellent high standard lectures, questions, comments. I think all of us are better after this meeting. excellent initiative. Thanks for the audience to choose to be with us on this Sunday. And thanks for all the professors that spend time to preparing lectures. And agree with Girish, it's very difficult to give on to delivery guideline for every country, every continent is different realities, but we can try to adapt for each continent or if each country. You do a very, very nice job. Congratulations, Girish. And maybe we can talk afterwards and try to adapt for the below of the Ecuador line. Thank you again and congratulations.
Thank you. Thank you very much, Professor Zanon. I take this opportunity to thank all the speakers, very distinguished speakers who took their time because they cared on a Sunday to give us their experience, expertise, and their foresight. For this is more than what we might even think. This is something that's not going to go away, and we really have to. We can't underestimate what we are up against. Thank you to all the participants who had come to this meeting. It really, this is for the participants, and I really appreciate your support for this. And so in concluding, I hope that we will have one in another 6 months to see where we are. Hopefully that will be a time that we will be going forwards. But I close this symposium with the words of Professor Salamova. I think this really requires amazing solidarity until we are out. Thank you very much, sir. Thank you, and wishing you all a great evening. I'm going to leave the webinar on for the next 15 minutes. So if any of you want to chat, please feel free. And please put that feedback form if you would like a certificate. Thank you very much. Wishing you all a good evening. Bye for now.
Thank you.
Thank you.
Bye-bye.
Bye.
Bye-bye.
Bye.
Bye.
Bye.